Hi guys, good afternoon. So let's wait for 2 more minutes and then we'll start. People are joining. Just 2 more minutes, we'll wait. Hi, please go ahead. Please start the session. Whoever is the host here.
Yes, sir. Welcome back, everyone, to the second half of the session. We hope that you had a refreshing break and are ready for more insightful discussions ahead. We now begin our post lunch session with a talk that promises to provide a much needed perspective on chronic neurological care. Our speaker is Dr. Anita Ansani, PharmD BCPS, a board certified pharmacotherapy specialist from Kowai Medical Center and Hospital, Coimbatore. Dr. Anita is a clinical pharmacy specialist with a focused expertise in epilepsy, stroke, neuroinfectious diseases, and neuroimmunology. She also leads the video EEG unit at the Comprehensive Epilepsy Care Center and actively contributes to epilepsy, surgery evaluation, and stroke awareness initiatives. Her session today is titled Deprescribing in Chronic Neurological Conditions, Balancing Symptom Controls and Safety. Please join me in welcoming Dr. Anita to the virtual stage.
Thank you. So is the slide visible?
Yes, Dr. Anita, thank you. Yes, it is visible very much.
Okay, let me start with thanking Dr. Ajit sir for inviting me to this session.
Thank
It's
you. Thank you, Dr.
something.
Anita, for joining. Yes, please go
Thank
ahead.
you, sir. Thank you. So, deprescribing is something we do often, and it's like on a daily basis, we have to de escalate or stop medications which is not benefiting the patient or causing more harm than what is expected. So, in neurology, what we used to do, we'll have a glance. So, as discussed previously, the importance of deprescribing in neurological condition is the same. We are trying to minimize the polypharmacy and we need to consider the changing disease course where the medications the patient is taking at that moment may not be as effective as it was expected to be. And we also have to consider the age related changes, the pharmacokinetics, the pharmacodynamics, and maybe the medication as such is not a good choice at that particular age. These factors have to be considered, and we need to have a close observation on taking a call on these medications to be stopped. And also, we need to look into the quality of life for the patient at that particular point of time and what side effects they have been facing from these medications. So, these are some points which we prefer to look into when we take a call on deprescribing. So, what are the key steps in deprescribing? So, it was already discussed in previous sessions. So, just to do a refreshing point, it's like assessing the medication regimen. So, what is the current medications which the patient is taking, and look for any potential drug-drug interaction at that particular point of time. It's like during each and every follow-up, many factors change. The blood parameters can change, especially the renal part. So looking into these factors will help us assess if this medication regimen is appropriate for that particular patient at that point of time. And we need to have a clear goal for that patient. So during each follow up, we have to reassess each and every medication the patient is receiving. We have to have a detailed discussion with the patient about how the medication is benefiting them and whether they are having any kind of issue with the medicines. Maybe previously they had good effect, but now or sometime recently they would
Uh,
have felt something wrong.
Sorry to interrupt, Dr. Anita. I think your slides are not moving and I think it's not on full screen.
I'll try once again.
Yes, please. Yeah, it's. Can you please make it full screen as well?
Is it visible now?
Visible, but not on the full screen.
Okay, I have put in slideshow.
Okay. Can you please? Yeah.
I'll just try again.
Yeah.
How about now?
No, not
Still
yet.
no. Okay, is it visible in this picture?
Yeah, visible, but yeah, not in the full screen. Yeah. I think that can be
Oh,
done.
shall we continue with this?
Yeah, please go ahead. It's perfectly visible, no problem. Please go ahead.
Okay, fine. So we were talking about the key steps in deprescribing. So first one was assessing the medication regimen, and second one we were discussing about establishing clear goals. So here we need to have a very open discussion with the patient to analyze how the medications are working for the patient. So each medication should be asked separately so that we'll get to know whether the patient is having any kind of trouble. It's because the medications will be given separately. We'll be having once daily dosing, twice daily dosing, and the patients may be taking it before the food or after food intake. So they'll have their own observations regarding each and every medication. So unless you sit and spend good amount of time with the patient, you may not know what is actually happening to them. They would have come to report any subtle events due to the medication, but if we don't spend adequate time with them, we may miss a significant part of our treatment regimen. And prioritizing medications. Again, if the patient is on multiple medicines, we need to always look into which one is going to benefit the patient the most. So, if you can cut down some medication which is not required at that particular follow up timing, maybe you can take it off and improve the medication adherence also for the patients. The third thing we need to focus on is tapering the medication slowly. So most of the medications can be stopped abruptly, but there are some class of medication which needs to be given utmost care when it is being stopped. So we have different schedules for each class when we do the tapering. Some require a weekly tapering, some might require a monthly tapering also. So going through the recommendations or the evidences, we need to stick on to the tapering protocol, which will help us to minimize withdrawal symptoms for the patient. And also, while we are tapering, we need to know whether we are causing any havoc, like worsening of the symptom for which the medication was prescribed. Along with that, we need to provide good support and convey what we are expecting from this particular deprescribing methodology. So, are we expecting them to have a better quality of life, or are we trying to minimize the symptoms or harmful effects which was caused by that particular medication? And should they be worrying about any new event? So, if we can give a clear picture to the patient, it will be very convenient, and they'll also have a better belief in us because they'll understand that we have control over the situation, and they'll be more confident in discussing further issues too. So, in neurology specifically, I have selected few disease states and few classes of medications which commonly we encounter while we do the deprescribing method. So, some diseases which I am going to discuss is epilepsy, dementia, Parkinson disease, and stroke. And the medication classes I'll be covering is anti-seizure medications, antipsychotics, dopaminergics, antiplatelets, statins, opioids, and medications other than opioids which is used for pain management. So, coming to epilepsy, most of the time we have patients who get good seizure control with a single anti seizure medication. But very few patients will require double or triple anti seizure medication as a combination to get good control of seizures. So, they may be on this uh, combination regimen for a pretty long time, and anti-seizure medications have their own side effects that has to be followed up and monitored closely. At any point of time, if we feel that the patient does not require these many medications, we often try to bring down or minimize the number of medication. So choosing which medication to be deprescribed is something we need to be very careful with. So if the latest add-on has brought the seizure control, it doesn't mean that particular medication alone is getting the epilepsy in remission. It could be that combination effect which is helping the patient to be in remission. So among the, for example, if the patient is on three medications, maybe we should go for the lowest potent drug or the one which after addition the patient had a seizure. So if the second drug addition did not give a good result but they had a good remission after the third addition, we can think about de-escalating or stopping the second medication. So again, once you talk to the patient will give us good feedback on which medication can be chosen for doing the deprescribing. So, having a good communication and asking the patient to observe their seizure remission or seizure control is very important before we decide on which anti seizure medication to be stopped. And the optimization part can be a reduction of dosage or making it something like the medicine which is given twice daily can be given as a once daily extended release preparation. So just bringing down the frequency alone can be a good benefit for the patient from the medication adherence point of view. And close monitoring is always required because when we deprescribe or when we de-escalate the medication dosing frequency or any alteration, it can result in a seizure. So reassuring the patient that nothing to worry, and if at all they develop a seizure, we'll wait or we'll take the next step is going to be very useful for them so that they'll be more confident to stick to our plan. So telling them what can be expected and what will be done if something happens against what we are expecting, it's always useful for the patient to feel relaxed and calm so that they can have a better quality of life also. Because worrying about their medication, what will happen if I decrease it, what will happen if I stop it, it's not something like a friendly situation for the patient. So you have to keep reassuring them and keep asking them or keep a close follow up with them whenever we do any medication change. And when we think about deprescribing in epilepsy, it's always a call between the newer generation medicine as well as the old anti-seizure medication. The older ones like phenytoin, carbamazepine, phenobarbital, they are very potent in controlling the seizures, and they are also very notorious in causing withdrawal seizures. So we need to be very careful if you are planning to deprescribe an older generation anti-seizure medication, because efficacy wise they are highly potent, and safety wise the newer generation like levetiracetam, brivaracetam, lacosamide or lamotrigine, these are all good from the safety point of view, but they are not as good as the older generations in control of seizures. So the withdrawal symptoms are more seen in the older generation one than in the newer generation. Coming to the next disease, which is dementia. So, one of the main class of medication which we have to be very careful in initiation is the antipsychotics. In dementing cases, the behavioral disturbance is something of concern. It's not that easy to control, and starting them on an antipsychotic is also something which is very worrisome, because the sedation part and the other side effects of antipsychotics is not going to be good for those patients. And there is good amount of data suggesting antipsychotic use in dementia will cause significant morbidity, and also there is a high risk of mortality. It is not a direct link, it is because these antipsychotics are known to cause stroke, falls, or pneumonia in these patients, which is leading to significant morbidity and resulting in mortality. So, we need to assess the necessity of this particular group of medication before initiation. Is it really required or not, or do we have any other non pharmacological medications that can be given for dementia patients? If at all the patient is on antipsychotics, once you achieve the treatment goal, you can consider decreasing the dose or using it as whenever necessary. We call it SOS, or as and when needed, we can give the medication. So this could be a better alternative than continuing antipsychotics in patients with dementia. And also, when you think about stopping the antipsychotics, the withdrawal symptoms on one side and the re-emergence of the psychotic behavior on the other side, both these have to be considered so that you can take a better approach for that patient, because it's not just the patient who is going to suffer with the withdrawal symptoms, it is also the caregivers, which is a nightmare for them, because the psychotic behavior in dementing cases are not something which is easy to handle, especially the patient is not in a good comprehension where they can understand what we are trying to tell them. So all that we can do or give them is these medication to calm down. So if that is not achieved, or when we stop the medication, if the situation is reversing, that's going to be a big problem for the caregivers too. So we need to be very careful before initiation and when we are trying to tapering the dose or when we are trying to stop these medications in this particular group of patients. Next disease, which the Parkinson disease, where we have so many issues in initiating the medication as well as decreasing the medication. So the main culprit in this particular group is the dopaminergic drugs, which includes levodopa as well as the dopamine agonists like pramipexole. So what happens is when we give this medication, the patients will get good control of the symptom. So basically in Parkinson disease, they'll have more of motor symptoms, which includes slowness in walking and slowness in almost all the activities, which is very disabling for them affecting their quality of life. So when the patient gets a good relief or good outcome with these medications, they will be happy with their life. But what if they develop some motor complications because of this medication? The main issue we face with levodopa is peak dose dyskinesia. So the problem with this particular event is that if you want to stop the dyskinesia, you will have to reduce the dose, or at some point of time you will have to stop the medication if the dyskinesia is very disabling. But once you try changing the medication, the patients will have recurrence of the Parkinson symptoms. Again, they'll go back to the slowness of all activities. So, balancing between the expected outcome as well as preventing dyskinesia like symptoms is a tough job. For that, most of the time, we'll have to admit the patient, closely observe them, and we'll have to adjust the dosing with a close monitoring, which might take up to 7 or 14 days inside the hospital. Because, as an OPD basis, doing the deep prescribing is a bit tough for this group because a change in a single dose can cause a significant change in these patients' symptoms. So that is with levodopa. And the other one problem which we have with Parkinson disease medications is the orthostatic hypotension. This is seen with both levodopa as well as dopamine agonists. So we know majority of the Parkinson disease cases comes under the geriatric group. So what happens is the baroreceptor reflex and the changes inside our body, the blood pressure regulation is not as good as the adult population. So on top of it, when you give dopaminergic drugs, there is a high risk for orthostatic hypotension. And if the patient is on antihypertensives for systemic hypertension, that is also going to complicate this issue. So what we do is we'll have to stop this medication. Mainly, we'll try to stop the dopamine agonist if they are going on with a combination medicine. We'll try to maintain levodopa because it is one of the basic medicine which is very much required for a Parkinson disease. So you can think about stopping or reducing a dopamine agonist like pramipexole, and then we can think about adding an alternative treatment option if the patient is having recurrence of symptom. If not, try to maintain the levodopa monotherapy alone and see how well the patient is doing. So, worsening of Parkinsonism or Parkinson disease symptoms is not that easy to get into remission also. Once they start getting the recurrent symptom, not always it responds to a new medication or change of medications. So, we need to be extremely careful and cautious when we touch their medicines too. If not, that will end up in a very poor quality of life for these patients. Next disease which I would like to discuss is stroke. So in stroke, we always start them on antithrombotics, which includes both antiplatelets as well as anticoagulation. So depending on the type of stroke and the injury or the brain area or the vessels which have been occluded, we used to give dual antiplatelets or single antiplatelet, or sometimes we'll have to combine antiplatelets with anticoagulation. So, as you all know, antithrombotics have a higher risk of bleeding, and most of the elderly patients will be landing up in stroke. They already have a tendency to fall because of the age related factors, and when you put them on these antithrombotics, one fall, a small head injury can result in a hemorrhage inside the brain, which is again another disabling condition for the patient. So we need to be extremely cautious when we initiate antithrombotics, and whenever required, we cannot stop ourselves from initiating this medication. So what we need to do is once you start them on this medication, we need to counsel them regarding the side effects. And most of the time, the initial phase will require a dual antiplatelet, and after 3 weeks or a particular period of time, we can convert it into a single antiplatelet. Or if you are giving an antiplatelet and anticoagulation as a combination, again after reassessment of the vessels or whichever part is required, we'll always have an option to bring it down to a single antithrombotic medication. So just initiating them on a dual medicine and then continuing it lifelong is not going to be a good option unless the patient is having such a bad condition, something like the whole vessels are atherosclerotic, or vessels are suffering from atherosclerotic disease, or there are significant occlusion in the main vessels. Rarely, some patients will require dual antiplatelet, especially when they are having recurrent strokes while they are maintained on single antiplatelet. If not, we can always try from converting dual antiplatelet to single antiplatelet so that it will reduce the risk of bleeding manifestations in this patient. And when you give antiplatelets, you'll always have to put them on proton pump inhibitors, especially if they are coming under the geriatric population. So, long term proton pump inhibitor is also not something welcoming because this group of medications has its own side effect. So, if the patient is comfortable with the antiplatelets and if they have not had any bleeding manifestation like an upper GI bleed, you can always think about stopping the proton pump inhibitor if the risk of GI bleeding is very less for them. So, in stroke cases alone, we'll have to take a call on antithrombotic optimization as well as stopping the proton pump inhibitor as when possible. So, counsel them regarding why we gave dual initially and why we are trying to stop it should be done very clearly. If not, the patient might worry about getting another stroke when we do this optimization. And in addition, we also give statins with antiplatelet therapy. So, statin initially will be given in a high dose. We always have to start the patients on high intensity statins, which will be like 40 or 80 mg of atorvastatin or 20 or 40 mg of rosuvastatin. So, maintaining high dose throughout their life is not always required. So, once they cross that immediate or the life threatening period, we can think about converting it into a lower dose of statins. If not, the elderly people, especially, or the renal patients, may not tolerate this dosing and they might land up in myopathy or myalgia, which is the pain or a disease of the muscles. So, these changes can be thought about and done in cases of stroke. Next one common problem which we see in neurology is insomnia. So for some patients it might be a temporary problem and for some you will require a prolonged therapy. So each and every time asking them about their sleep after initiating benzodiazepines or the sleeping pills is very necessary. Or you can even counsel them telling let them start with the medications we prescribe and let them try deprescribing it themselves. So they can either minimize the dose or they can try stopping the medication and see whether they are getting good sleep or not. As soon as possible or whenever possible, if they do it, it'll help them to come out of the medication. Or they'll always have a feeling like I'm addicted to this medication and without this I cannot sleep. So reassuring the patient, telling them there is a possibility of getting back your sleep even without the pills is going to be very useful because this thought alone can cause depression for these patients. So, helping them come out of the state, making them understand what are the causes of insomnia, and going for other behavioral therapies or non pharmacological interventions, many a times will help the patient more than the medications which we are prescribing. And there are good number of side effects for these sleeping pills, which include sedation, resulting in cognitive decline and falls, which is again going to be another disabling event for those patients. So whenever possible, start with low dose and slowly titrate. And as soon as they achieve their good sleep, try tapering it and stopping that medication. If not possible to stop, at least tapering the dose will help them to get good sleep. So unless we try, we are not going to know whether the patient will benefit out of this. So keep telling the patient what we are trying to achieve and let them know that stopping this medication is also an option for them and they'll also get good sleep even without medication. So slow tapering is very important because benzodiazepine immediate withdrawal can even cause seizures. So we need to be very careful in initiation as well as in tapering and stopping this group of medicines. Another common problem which we have in neurology is pain management. Most of the time, patients come with neuropathic pain. So, patients who are chronic diabetic cases, they'll have a tendency to develop this neuropathy, which may not respond to one or two medication. We'll have to try different medication, or we'll have to try even combination medicines. And all the groups or classes of medication which is used for treating neuropathic pain is not something very friendly for the elderly group, especially. So, NSAIDs usually don't work for neuropathy, but for other conditions like osteoarthritis or other painful condition like some disc prolapse which is causing a pain, myalgia pain, these patients will benefit from NSAID, but it should be given for a short course. So starting the medicine and the patient not coming for follow will end up in the patients continuing these NSAIDs. So telling them or counseling them that this should be stopped after a particular period of time. So even if they don't visit us, we should ask them to do the deprescribing themselves. So not to continue the NSAID, that counseling should be specifically done for these patients. If not, we have had patients who have come back with a 1 month intake of NSAID, and at last they'll land up in renal impairment. So always tell them what is our treatment goal, how long we are planning to give this therapy, what we are trying to achieve, and when we are trying to stop it. If not stop, what will happen? So focus more on the follow-up part and tell them why we want them to come back to us so that they'll understand the importance of review or follow-up. And the next group, the opioids. So we'll have to give tramadol, or sometime we'll have to go for fentanyl patches also. Something like post-herpetic neuralgia, where the patients will get neuropathic pain after a herpes zoster infection. It is a very bad condition where you cannot tolerate the pain at all. And most of the time, none of these medications are going to give any relief for the patient too. So one of the opioid which we use or which might give some response is the fentanyl. And on day one, when we initiate it, the patient might feel very much sedated or drowsy. And if they are not given this counseling, they might land up in a fall because of the drowsiness part. So fentanyl or the opioids can be used for again a short period of time, because as time goes, the pain will start to settle. So after a certain period of time, we can de-escalate or stop these medications. And if we don't tell the patients regarding that particular period of time which we plan to give this medication, they'll have a tendency to continue this out of fear, because they'll feel like if they stop the medication, they'll have this rebound pain. So telling them about the disease and the disease course and what is expected for them is always important, so that even if we are not deprescribing it, at least the patients will try doing it and they won't continue this medication. And other classes of medication which we use for the neuropathic pain medicine is the GABAergic drugs and the antidepressants. Most of these medications have very strong anticholinergic properties, which is not very friendly in elderly population. And so, close monitoring, de-escalation as soon as possible, or telling the patients to switch over. Like if one is not working or if they are not tolerating one medication, we always have an alternate option. So for neuropathic pain, one advantage is that we have good number of medications which can be given a trial if the other medicine is not being tolerated. So we have low potent medication to high potent medication, and we have varying side effects for each medication. So from this choice of options, trying to get the best one for the patient, that should be communicated well so that they can come back and we can do the deprescribing as and when necessary. And if required, we can switch off the medication. So, whichever disease, whichever medication, open communication is very important when we are trying to do a deprescribing process. So we went through the neurological conditions where we require deprescribing. Now I would like to take you through some medications which can worsen the neurological condition. So we need to be vigilant when these patients, when this particular diagnosis comes up. It is because the patient may be on some medications for a pretty long time, but they would have been given a diagnosis sometime recently. And we'll have to take a call on changing the medications which they were already on. For example, when a patient is newly diagnosed with myasthenia gravis, these patients, if they have a cardiologic condition and if they are on beta blockers, so beta blocker is something, is a group of medicine which is very important for a cardiac patient based on the indication. And in myasthenia gravis, beta blockers are known to worsen the myasthenic symptoms. It is one of the class of medication which is absolutely contraindicated because patient can land up in a myasthenic crisis, in which the symptoms might be very bad respiratory failure, where the patient will require ventilation, and it's not all the time we'll be able to save them. So, if the patient has been given a diagnosis of myasthenia, we need to go through the medication regimen thoroughly and make sure the medicines which can worsen myasthenia is not there. If at all, we'll have to have a communication with the that particular consultant. For example, if it is a beta blocker, we'll have to talk to the cardiologist or tell the patient that this medicine is not a good choice in this particular neurological condition. So we'll have to tell them to alternate that beta blocker so that it won't cause any new issue for this patient. Same thing applies for Parkinsonism or Parkinson disease. So patients who are on antipsychotic medications, the antipsychotics have a tendency to cause extrapyramidal symptom. So most of the extrapyramidal symptoms are symptoms which we see in Parkinson disease. So when we stop antipsychotics, we can reverse the extrapyramidal symptom. But if we are giving a diagnosis of Parkinson disease, this antipsychotic medication can worsen the situation. And if it is not stopped immediately, maybe the medicines which we give for treating the Parkinson disease will not provide adequate effect. So, stopping the antipsychotic again should be done in consultation with the psychiatrist if the psychiatrist has initiated this medication, and we'll have to go for alternative medicines which have the which is having in the least EPS symptom, or there are safe antipsychotic options which is not having any EPS symptoms at all. So many times a new diagnosis will tell us to go through the medications the patient is on previously so that we can make adequate changes. And in some cases, we'll not even have to initiate any new medicine. Just stopping the medicine will give good recovery for the patient and a close monitoring of the symptoms. If it is worsening, we can think about adding a new medication. So avoiding prescribing cascade, which is like one medicine is causing an issue, and then instead of stopping that particular culprit medicine, adding a new medication to take care of the side effect. This can be avoided. So it's not just about avoiding initiation of a new medicine, but it is also about stopping the medication which is causing the problem. Likewise, we have some medicines which can cause seizures. For example, tramadol or linezolid, and some medicines, some antibiotics, other antibiotics like imipenem or cephalosporins, they are well known to cause seizures. So, if a patient has been diagnosed with epilepsy, we always counsel them to avoid medications which are highly potent and causing seizures. So, in that list, we usually include tramadol, linezolid, and fluoroquinolones to mention. The cephalosporins or other beta lactams are not that notorious, but if they develop a seizure while initiating this medication, we'll ask them to avoid it. If not, we can just tell them to strictly avoid tramadol, linezolid, and fluoroquinolones because they are well known to cause seizures. And these medications are given as an OPD basis. So we don't include the parenteral medicines which can cause this issue because once they get admitted, they'll be under close monitoring and observation and things are under control. But as an OPD basis, we'll always give them a list so that they can show it to their consultant if they are going to a different hospital so they can avoid initiating this medication which is known to cause seizures. And again, the antihypertensives, a patient who is having a stroke or who has been diagnosed with Parkinson disease, we need to make some optimization of antihypertensives based on the problem they are facing. In Parkinson disease, we already had a discussion regarding orthostatic hypotension because of dopaminergic drugs and levodopa. In stroke, the problem is that we have different blood vessels which is carrying blood to the brain. And during the evaluation of stroke, we always look into the angiogram and see how many blood vessels are occluded and which blood vessel is occluded. If the main blood vessel is stenosed, which means it is not fully occluded, but it is almost blocked to 70, 80, or 90 percentage. So we'll have a small 10 percentage gap for the blood to flow. For these patients, if we try to control blood pressure very in a very tight way, that is going to cause hypotension related strokes. So patients who have a significant stenosis in the major blood vessel, we tend to have a liberal control of the antihypertensive. Even if they are on multiple antihypertensives, we'll try to minimize the antihypertensive medication so that we can prevent a recurrent ischemic stroke because of hypotension. So these situations should also be considered where it may not be having a direct link, but indirectly it can worsen the disease condition. And of course, when we improve their symptoms or when we try preventing a new problem, it is always going to improve the medication adherence for these patients. So the last slide was all about what the medications, how the medications can worsen the neurological condition. Now, there are some medications which can induce neurological problems, and of course, if a medicine is causing a side effect, we'll have to stop it. But identifying the problem, so identifying the symptom and putting a name for that diagnosis is very important so that we can trace it back to that particular medication. So, in elderly, encephalopathy or delirium or hyponatremia, which is low sodium level, is something which we see commonly. And most of the time, this is because of medication rather than a new diagnosis which is having this issue. So, just identifying the medicine, tapering or stopping it will give them good symptomatic relief, and then we'll have to counsel them to avoid this medication or that particular class of medication so that they won't get any recurrence of these events. So again, I'm sure this was discussed previously. So we have multiple challenges in deprescribing where when we tell them about stopping or reducing the medication, they'll always have a fear of recurrence of symptom. And what if they lose this control over those symptoms? What if they don't achieve the same control when the medication is restarted? So they may not be very happy to go with our deprescribing suggestion. And it's not that for all medication we have good evidence on how to taper or how to stop the medication or which medication to be chosen from that particular set. So that's again something difficult for us. And only for geriatrics, we have different criteria like BS criteria, start and stop criteria, or medication appropriateness, inappropriateness. This index, there are multiple scales that can be utilized or multiple evidences are there for the geriatric population. Otherwise, for most of the cases, you'll have to do a case-based analysis looking into each and every medication and the symptomatic control and how the patient is uh, what is the quality of life for that particular patient at that point of time. It may not be the same throughout. So during each follow-up, we'll have to have a close analysis by talking to the patient as well as the caregivers. So again, once we take a decision, if the symptom is being exacerbated, they may not be very friendly in discussing it with us. They may lose the confidence and they'll feel like it's better to continue the medication rather than stopping and getting new symptoms. And of course, whenever you take a call, if the patient is having comorbidities, it is always better to talk to the healthcare professionals who all are involved. So they'll give us a better point of view and we can also discuss our concern, and the best decision for the patient can be taken with an interdisciplinary coordination. So, how to do a better deprescribing? Collect relevant information from the patient as well as the caregivers, and if required, you can talk to the healthcare professionals also. Identify the drugs and decide on the drugs which require deprescribing. Plan it for the patient, implement it, and see how they are responding with close follow up. And of course, we'll have to do a shared decision making where we'll have to explain them, get their feedback, include them in taking a call, and always keep the healthcare professionals, other consultants, or other people who are involved in their care in the loop so that we'll have the best decision for our patient. So that's all about deprescribing in neurological condition. So open to questions. I guess there are not much questions in neurology.
Hi guys, who is taking over? Hello, guys, who is taking over next from my hosting team? Okay, any questions, guys? Please ask your questions if there are any questions.
Neurology is so easy, so there won't be much
I
questions.
think the the participants have understood everything perfectly, and it was really a brilliant session. It was really amazing, and you have given the wonderful examples from neurology perspective. Dr. Anita, thank you very much for accepting our request and delivering this session. It was amazing. I think you had yesterday the live session in there only, right? Yesterday, some live conference was there, and Dr. Solival Rajan was also there in KMCH. He went there. I was seeing the prospectus. Okay, so no questions, guys, is it? Wow. Either you understood everything or you were sleeping after lunch. I'm very sure.
Yeah, post lunch neurology, it's a very good combination. So
Yeah.
So if
So
there are any
there is a very
questions,
good.
there aren't any questions, then we would like to continue with the picture, right?
There's a very good strength though. We have 200 plus people in Zoom and we have almost 50 people in YouTube. Okay, still no questions. Then it's very, very, something like, okay, let me see the YouTube ones. Is there any questions in YouTube? Surprisingly, no questions in YouTube as well.
good. So we'll take it as they understood the neurology part, and I'll be happy. Thank you.
Thank you. Yes, please go ahead, Insa.
So if there aren't any questions, we would like to continue with the picture.
There is one question from Glass-T. Glass-T, one question is there. Can you please take this question?
Yes. Ma'am, the question is, um, can we recommend to stop anti-epileptic drugs if patient didn't have an anti-epileptic episode within 6 years, or a minimal dose should be continued for lifetime? It's from Paul, someone.
Okay, so stopping anti-seizure medications in epilepsy is a very tough scenario. Basically, you need to know what is the syndromic diagnosis. There are multiple types in epilepsy, and we will have to know what is their basic diagnosis, what is their brain imaging showing, and we need to know the nature or the course of that particular syndrome. Some syndromes, something like, for example, if you take a juvenile myoclonic epilepsy, which comes under primary generalized epilepsy, they tend to have a minimal seizure occurrence. If they are controlled with two or three medications, we can think about bringing down to one or two medicines actually. But again, it all depends on how long they have been seizure free. So it's not just the number of years or the duration of seizure freedom, but it always comes to the diagnosis, the syndromic diagnosis, which will help us taking a call on that. If a patient is having a post-stroke seizure, they'll always have a scar on the brain with a tendency to cause recurrent seizures. Post-stroke seizures usually respond to single anti-seizure medication, Unless they develop another seizure while on medication, we don't add a second medicine. But if they were started on two medicines initially, and if they are having good seizure control, we can bring it down to one anti-seizure medication. So it's not like seizure patient or an epilepsy patient, seizure freedom for 6 years and then stopping medicine. Because if their particular diagnosis, something like if you look into Lennox-Gastaut syndrome, if you try minimizing medication for a patient who has been controlled for 6 or 8 or 10 years, and if they get another seizure, it may not be that easy to control it further. Restarting the same medication which was stopped was not going to help the patient also. So, take home point is it all depends on the syndromic diagnosis and the nature of that particular disease. Okay, I think I'll take the next question.
Ma'am, yeah, the next question was, do we consider the patient's pharmacokinetic parameters while deprescribing?
Yeah, of course, we need to consider that because the kinetics and dynamics will help us in identifying the toxicity or the intolerance or why the patient is not responding. So, either way, kinetics and dynamics both are going to help us in deprescribing. That's a wonderful question, but it's something very important.
And there's one more. Are there any interactions between sodium valproate and itraconazole or other derivatives from fungal infections? Are they safe to use in simultaneous manner?
Yeah, I need to use my reference for that. I don't memorize it, so I'll have to check that part and get back to you. Maybe I'll check and I'll put a message. Okay.
Yes, ma'am.
So, yeah.
There is one more, right? Will there be any effects on the memory power of the brain due to the prolonged use of anti-epileptics, like for 20 plus years?
Okay, so for among the anti-seizure medications, topiramate is well known to cause cognitive dysfunction. Other than that, usage of anti-seizure medications for a prolonged period of time is not going to directly affect the brain. But if you don't take the medication and the patient is getting recurrent seizures, especially the generalized tonic-clonic ones, that repeated seizures can have a cognitive dysfunction rather than the anti-seizure medications as such. Only medicine you need to be worried about is the topiramate. And if the patient is complaining of cognitive dysfunction or the parents are coming and telling us the child's scholastic performance has come down, we always do an assessment on the onset of that particular issue, whether it started after the seizure onset or whether it happened after initiation of topiramate. So in those conditions, if you get a clear evidence that topiramate is causing an issue, we'll tend to stop it. Other than that, you don't have to worry about cognitive dysfunction because the patient is taking anti-seizure medication. Of course, we'll be following up the patient regarding how they are doing, and if at all, if the memory disturbance is a significant disability for that patient, we'll look into adjustment of the medications. It's not well known, but it can happen. But I'll tell that you need not worry about that part. If something is there, we'll always have an option to optimize the medication.
Thank you so much, Dr. Anita, for that highly informative and thought-provoking session. Your insights into deprescribing in neurological conditions were both clinically relevant and deeply impactful. We truly appreciate you taking the time to be with us today. With that, I now hand over the stage to my co-host, Devanshi, who will take the next session forward. Over to you, Devanshi. The stage is all yours.
Thank you, Insha. Good afternoon, everyone. I am Devanshi Barod, your host for the next session. Now, I hope you all are energized and ready for what I personally think is one of the most futuristic sessions of our conference. In today's times, technology is as important as food and water for survival. But can technology be a partner in optimizing medications? Well, let's find out in our next session about tools and techniques and artificial intelligence in deprescribing and medication management. As deprescribing evolves, so do the tools that support it. And in today's digital era, technology is becoming a powerful ally in helping us optimize medication use more effectively. Guiding us through this fascinating topic is Dr. Neha Suratia, a distinguished healthcare professional with a doctorate in pharmacy and extensive expertise in clinical and pharmacy practice. She is a passionate educator, author, and course director at Climate Academy. She is also the author of the book Drug Related Problems and Their Overcomes. She has also contributed in the scientific community with 12 publications in esteemed national and international journals. She brings a perfect blend of clinical expertise and innovation for all of you. Let's discover how AI can become a pharmacist's new best friend. Over to you, Dr. Neha.
Okay, so thank you so much, Devanshi, for the introduction. And I'm really grateful to take your next session on the machine learning and artificial intelligence. So, till this session, I think we already understood the concept on deprescribing and the polypharmacy management. Okay, so the criteria is what we are already having, the Beers criteria, the stop and start criteria, and many things we already discussed, okay, till this session. And this session is something which is going parallel with what we theoretically understand. And this session is totally about the artificial intelligence and machine learning, how these two things are working and aligning with our deprescribing and management strategies in case of polypharmacy management. So this is very personal and my favorite topic to always discuss about, because this is not something general, but we need to be very skillful enough to understand what is the use of AI, because everyone can be having the idea of what theory looks like of the artificial intelligence using and machine learning use, but the practical aspect of using it, the softwares, the databases, how it looks like, how to monitor it, how to use it, that is very important as per the healthcare professionals. So every healthcare professional needs to understand that these technologies are emerging further, and we need to practice it in our daily life. Here I want to give you a disclaimer that this artificial intelligence does not solving our all queries, right? And machine learning is not giving you all the solution of diagnosis and everything else. We need to be very precise with the theoretical concept of pharmacology, the therapeutics, and so on, whatever disease we learned in our course. So basically that is very important. This artificial intelligence and machine learning is a co-factor that may be used in the plus sign. So you are equipped with the very best, at your very best theory knowledge, and simultaneously you are using artificial and machine learning to just for your to say for time saving purpose, or maybe some quick revision purpose, or maybe some of the ADR or adverse effect monitoring and the medication management. So it is not completely, you cannot completely and 100% depend on the artificial intelligence. So many of the people are having that question on their mind that how this artificial intelligence are replacing the job of humans. So basically it is not replacing, but let me tell you, AI does not replace your job, but if you don't know how to use AI, that idea may be the reason behind replacing your job in the future. So that's the only reason why we have topic of discussion today, the artificial intelligence and machine learning in deep prescribing, okay, and the management of polypharmacy. So let me just share my screen with all of you, and we'll get back to you at the end of the session. I hope you have questions to ask at the end. We'll solve one by one, right? So please, if you guys are sleeping after lunch, please wake up, because these are some of the very good topic to discuss about machine learning. Okay, sharing the screen. Just wait for a minute. So I hope my screen is visible.
Yes, it is, ma'am.
Okay, so we can proceed. Okay, so we are today discussing about the deprescribing and medication management, the role of AI in this. Okay, so again, I welcome you to this session and we will explore how these emerging tools, techniques, and artificial intelligence are, transforming the way we approach the describing, the deprescribing, and the medication management, particularly in the context of polypharmacy and aging population, right? So with the increasing complexity in the patient care, we know now what how complex the prescription looks like, right? So with this increasing complexity in the patient care, clinical decision support system like the softwares are also there. Some of the very good examples I have in my mind, that is med stopper, med safer, and this AI enabled platform such as the taper is also there. These are now playing very crucial role in optimizing drug regimens. Reducing adverse event is also those factor, and enhancing patient safety is our goal behind this. So this session will walk you through how these technologies work together, their clinical applications, and how they integrate evidence based criteria like the stop and start to support some rational prescribing. So let's look at how digital innovation is reshaping the future of medication review and the personalized care itself. So moving forward with the title of our session, that is tools and techniques we are going to discuss, and artificial intelligence in deprescribing and medication management. So what are the learning objectives for this session? So by the end of this session, the learners and you people should be able to understand the concept and importance of deprescribing, what you already understood. I think there are some 4 sessions, right? So you already got the point of the importance of deprescribing. Second point, that is by the end of the session, you will be able to identify the specific tools and techniques which are existing globally in the medication review and optimization. And third topic is you will be able to explore the role of artificial intelligence and the machine learning in deprescribing and medication management. Also, you will be able to analyze some real world examples of the AI driven clinical decision support. Okay, so everyone has now idea what is the CDSS, that is clinical decision support system, but how it is working like AI driven, right? What is the emerging trends the AI and the machine learning has? So that is our topic of discussions and the learning objectives of the session. So yes, it is very important that the artificial intelligence and machine learning can significantly enhancing the application of this stop and start, start criteria, which already we understood in the previous sessions. So how these softwares are working, how the data integration is happening, and what are the challenges in it, that is the topic of discussion. Okay, so basically let me just tell you what is AI. So briefing about AI is you just need to understand that artificial intelligence is nothing but a comprehensive collection of real case based data that gives you some instant we can say comprehensive learning outputs based on whatever you have put it into the in a form of just props. So basically you need to tell them that what you exactly required, and they will do, the AI will do some of the global research and providing you some of the best learning objectives which are associated or aligning with your query. So that is nothing the examples of AI, right? So everyone now maybe in use of the chat GPT, and everyone used to have that practice in your daily life, whether it is for the image search or whether it is for the some other information on what is the best place to visit and everything else. So basically that is exactly aligning with the healthcare facility. So AI is a emerging trend, right? And it is emerging in the CDSS, that is a clinical decision support system. So we need to understand that what are the major roles of this particular machine learning in the CDSS that needs to be understood by the healthcare professionals, and how to use these softwares in the real life. That is the exact question, right? So let's start with the introduction of deprescribing. So I'm just revising it because I think very since first lecture we have the definition in our mind that what is deprescribing. So basically it is the planned and supervised process of dose reduction, right? As its name suggests, it is a deprescribing. So it is a planned and supervised process of dose reduction or stopping the medications that may no longer be beneficial or might be causing harm, right? So why it is important? So in case of the polypharmacy management, especially in the elderly or some multimorbid patients which are having a comorbid conditions, or maybe the risk of drug-drug interaction is very high, in that case also you can prefer deprescribing if you are having some of the predictable and unpredictable side effects and reduced adherence. That is also the case where the deprescribing is being preferred. Also, to improve quality of life and reducing healthcare cost, that is also the need for the deprescribing. See, there are multiple needs apart from whatever listed here, but we already know this concept, right? But before initiating directly jump into the AI and machine learning, I just want to brief you about the introductory part, because what we are learning to revise everything is very important, right? So let's just have example of the clinical example here to understand the AI and machine learning. So we will be having a AI and ML in the upcoming slides. So you just need to focus on this clinical example for now. So here it is a short stopping the long-term proton pump inhibitors when it is no longer indicated. Now, if you are practicing, if you are a healthcare professional, right, or becoming a healthcare professional, you at any time of your daily practices, so you observe that kind of things. Proton pump inhibitors are widely being used in the prescription, so and for the longer period of time, right? So here is the background. So PPI are widely used to treat the conditions like GERD, peptic ulcer, and gastritis. Often it is started in the hospital setting for the stress ulcer prophylaxis treatment, but not always stopped after the discharge. That is very important thing. So what is the problem associated with this particular scenario? Many patients remain on PPI for months or years without a clear ongoing indication. Maybe you will be having examples in your own household also, the people who are taking PPI like a breakfast, right? So basically that is happening with our system. Long term use is associated with so much of the risk. You can see here it will increase the risk of fractures due to some calcium malabsorption. It is initiating the the side mechanism is happening with the long exposure of PPI. Also, some of the risk is there for vitamin B12 deficiency or Clostridium difficile infection, maybe on the resistance form. It can goes. Some of the chronic kidney disease happens in a very rare cases, because obviously we know the pharmacokinetic parameters of PPI, right? So these are the problems associated with the longer use of the proton pump inhibitors. So when to consider deprescribing in that case? So GERD symptoms resolved. If it is once resolved, you can just simply stop using it. No current NSAIDs use is there, or no steroid use is there. In that case also the deprescribing should be there. No history of bleeding ulcer and the patient is stable and asymptomatic, so they can obviously prefer deprescribing of PPI. So what can be the strategy of deprescribing here in that particular case? So gradual dose reduction, obviously it can be understandable that from twice daily to once daily they can go, and then move forward with the every other day and then stop it, right? So that is nothing but a tapering a dose in a particular manner. Also monitor for rebound acid hypersecretion. You need to check it that the relapse is happening, or the recurrence is happening or not, and offer some of the alternatives if needed, just like the antacid or for the mild symptoms, right? So here is the case to understand further what is the role of AI. That is, you can see here the example, which is then for the elderly women who is taking a pantoprazole 40 mg daily for the 3 years. You can see the time period here. It is 3 years. Originally started during the hospitalization, and she has no current GI symptoms. So in that case, using a stop criteria is very important. Okay, and also the mad stopper. Now that is the introduction of something which is the heart of our the session, and that is nothing but the artificial intelligence and machine learning, which takes you towards the journey forward, right? So basically this is very important to learn that in the stop criteria also, or if you are going for software like the mad stopper, it is suggesting you when to stop taking certain medicine. This is a very simple example of proton pump inhibitors, but just you just need to understand that this is the same thing exactly being there for all other complicated cases as well. So PPI is again tapered and discontinued as per the software suggestion, and she reports no reflux in that case. Lab test also shows improved magnesium level, which was previously decreased because of the prolonged use. So that is how the you can go for the stop criteria and med stopper in the clinical way. So how exactly this question came, that is how exactly the AI and ML, machine learning and artificial intelligence, can be applied to this stop and start category in the polypharmacy. That is we need to understand. So basically that has a multiple things inside it. Very first we'll understand how this AI and ML applied in the clinical decision support system, okay, CDSS. So now you know, I think in one of the sessions CDSS discussion were there. So basically clinical decision support system is there. It is an algorithm that can be shown to you for, you know, some of the timely clinical decision a healthcare professional can take. But in that case you can further integrate the AI algorithms. So you can see the bold point here, that is AI algorithms can be integrated into electronic health records. Now, let me tell you, this is very, this seems very easy to read. It seems very easy to understand as well, but in a practical way, there are lots of challenges in integrating AI algorithm in the electronic health record, because EHR itself, it is a challenge for us because we need a huge data security if we are proceeding with the electronic health records. But in the Indian scenario, if I can talk, many of the big hospitals are already doing these things, right? Electronic health records. That is basically on the purpose, because if you are, you know, specifically working in a particular ward, and if the ward is having electronic health record, you can check it, what are the resistance strains in your particular community setting, right? Just like the antibiograms of the hospital. So electronic health records gives you the idea about the resistance pattern. Also, what are the commonest diseases you can find out, what is the ideal treatment chart which is used in your setting, you know, healthcare setting, and what should be avoided, what should be predictable side effects which can be there because of drug induced, right? So drug induced side effects, all over the information about the prescription should be found at a very first click, that is electronic health record. So here they are suggesting that you can integrate your AI algorithm in the EHR only, right? So to automatically screen the medications against stop and start criteria. So if you are using a specific medicine, for example, you are using a benzodiazepine, so they are showing you the criteria. It is showing you the criteria that when to stop it, in what circumstances you need to again restart, right? What needs to be there, what symptoms should be monitored, and if you are restarting it, what needs to be monitored later. So that is all will be on available on a single one click. Okay, so basically that is the whole scenario. The AI and ML is working towards the clinical decision support system, and they can generate real-time alerts, as I earlier said, right? It is available on a one single click for inappropriate prescription or a mistreatments as well. So there is one code that the humans can do some of the errors, but AI cannot. So basically they are, it is showing you the results, the inappropriate prescriptions or some mistreatment in case of it is missed. So for example, we have here the example AI enabled, agar if it is a clinical decision support system which is AI enabled, that flags a benzodiazepine prescribed to an 82-year-old patient with a history of falls. Now this is very important, right? So if you are entering the data of your patient's specific demographic details into the system, for example 82 years of age, right? Patient already had a history of falls, and you are writing your prescription like that is a benzodiazepine in that particular case. So it will give you a real time alert that if you cannot go for this medicine in particular this patient. Why? Because benzodiazepine, if prolonged period of use in the elderly patient, can cause the history of, the fall, right? So basically if the patient is already having history of falls, you cannot proceed with the same medicine further. So that is what it slips maybe in from the our mind, but it is the AI that has the algorithm in the CDSS system that is showing you the alert at a very single click, and that is nothing but the system making you aware in the real time, right? So basically that is example to understand the importance of AI enabled CDSS. Okay, and it is aligning with the stop criteria. It will suggest you that stop using benzodiazepine in a particular patient. Either you can go for, if the indication of benzodiazepine is for only a sleep management, you can go for CBD treatment or any alternative options available, but you cannot go for this medicine because it is associated with the fall risk. So this is how exactly the system is working, right? Also, how it is helping. So secondly, it is helping you to predictive analytics for the adverse drug events. As I earlier explained you, some of the very commonest one, and in the moderate also level, it can show you the adverse drug reaction possibilities. So machine learning models can be trained, okay, on a large data sets. As I earlier said, it is nothing but a combination of a very huge and a large real data sets to predict further the likelihood of the adverse drug events based on patient's profile and the drug combinations a person is having. So everything needs to be entered in the system, and it will generate data according to whatever huge amount of data it integrated into the system. So this can help to prioritize further which medications to review, okay, and which needs to be done further, what modifications needs to be done using the stop and the start criteria. So that is the important thing. Like, it is a very good predictive analytics for adverse drug reaction and the events also. For example, we have here an machine learning model which identifies patients at high risk of GI bleeding due to NSAIDs without PPIs. Now, if you are using this particular sentence, and if you are entering it, it will show you the whole list in which condition you cannot go further with the NSAID without PPIs. Okay, so obviously it is not convenient to use NSAIDs, but in that particular case, right? But it gives you a real-time alerts, prompting reviews via stop. So it will be alerting that stop using this medicine in particular patient. So see, this is the second thing which can the AI and machine learning can bring into the case medication management, basically predictive analytics for adverse drug events. Third thing, that those are the miscellaneous one, but let's just talk about it. AI and machine learning can also contribute toward the patient specific customization, right? So we are now talking about the personalized medicine, the precision medicine, whether it is oncology, okay, and some of the cardiology, neurology. So basically, precision and personalized medicine required a very patient oriented treatment, very patient specific customization. So in that context also, AI can tailor the stop and start application based on individual patient data, like what is the renal function of the patient, what is the status of the frailty index, right? If you have the idea, frailty is nothing but the weakness, right? So frailty index estimation can be done by using a scale also, which is a frailty assessment scale. So that needs to be checked. Comorbidities needs to be checked, and genetic markers. If you know, genetic markers are playing a huge role. So nowadays we have another foundation of the term, that is the pharmacogenomics, right? So that is nothing but the patient's gene is very responsible for the to identify what will be the response of the particular drug. So gene drug interactions are also happening. So we have only a three interaction till date in our reference book, that is the drug food, right, and the drug disease. But the fourth one is the gene drug interaction, which is coming in the recent future. And we also know that many of the drugs are getting metabolized by the CYP450 enzymes, right? And these genetic makeups of this particular enzyme is making people into different categories, like whether the patient is rapid metabolizer or ultra rapid metabolizer or a slow metabolizer, right? So there are a category of metabolizing such drugs. So that is also needs to be understood in case of personalized medicine, right? So we already had that course also, the genomics and personalized medicine. So genetic marker should be also in our list to check. So if you can enter that thing, AI can generate a patient specific customization, what to have, what to have the in the treatment chart for the specific patient. Also, AI can machine learning is very helpful for the natural language processing. So that is a NLP actually. And this NLP algorithms can also extract some relevant clinical data from the unstructured clinical notes. In many of time, I have also experienced this kind of things while looking at the prescription, that it is, very unstructured in form. So that can be also that problem can be also solved by the machine learning. So basically, for example, history of falls, or poor renal function which is not written, so that can be also assumed, and to support further the automated stop and start checks. So natural language processing can be done by using the AI and machine learning. Also, there is the fifth number where the AI and machine learning can play a huge role is optimization and simulation tools. So basically, AI tools can simulate further what if scenarios. Okay, so that is very important again, because every time we want to taper the dose or we want to continue, there is always a question what if scenarios, right? So basically, in that case, what happens if the certain medications are de-prescribed or replaced? That is also the solutions are with the help of AI and machine learning, you can identify. So it is help further the clinicians to balance the risk benefits ratio in the polypharmacy, right? So this is again at where the AI and machine learning are playing crucial role. Also, we have on the number 6, where the AI and machine learning has a role is learning from the real world data, right? So machine learning models can continuously learn from the outcomes of stop and start, which is based on the interventions, improving further the accuracy over time, because it is all updating themselves itself actually. And the data is integrated, is very evidence based and new. So basically, that is improving the accuracy over time and adapting to local prescribing practice as well. So these are certain areas where AI and machine learnings are important in the clinical decision making. So these are the combined benefits you can see here of the artificial intelligence and machine learning integration in the stop and start use. Basically, it is improved accuracy and consistency in applying the complex criterias, time saving for clinicians. So as I in introductory part I explain you that it saves time because it has a real evidence based data on a single click, right? So it is time saving for clinicians. Also, reduction in potentially inappropriate medications, as the same name itself has meaning, potentially inappropriate medications. So whether it is NSAIDs without PPIs, whether it is benzodiazepine and elderly patient, everything can be generate a single sentence that if you can follow the stop and start criterias in particular situation or not, right? So it can obviously reduction is happening in the potentially inappropriate medication, and also better patient outcomes are associated with it, with the fewer ADs, that is adverse drug events, and it can obviously decrease hospitalization as well. So these are very important aspect of where exactly the AI and machine learning play an important role. Let's see one of the example again, which is already I told you that discontinuing benzodiazepines in the elderly due to some fall risk. So we have some of the examples as in medications, lorazepam, diazepam, alprazolam, right? So what is the background of this? Benzodiazepines are used for anxiety or insomnia or the agitation, right? So in the older adults, it has a very longer half life and increase the CNS sensitivity as well. So it is very important to check whether the elderly patient is supposed to take it for the next time or not, right? So what is the problem? The long term benzodiazepine use in the elderly is linked with increased risk of falls and the hip fractures, daytime drowsiness, confusion, and memory problem, which is already age related, right? And with benzodiazepine the risk will be more, higher risk of delirium and hospitalization, and also some of the case like dependency and withdrawal symptoms may be there. So these are the problems which might arise with the use of this example medicines. So where what is the role of AI, will see when to consider in that particular case the deprescribing. Elderly patient with the stable anxiety, you can suggest the deprescribing in that case. High fall risk or history of falls, right? Use for more than 4 to 6 weeks because it is very prolonged time. Also, in case of polypharmacy, you can suggest deprescribing. So what is the strategy here? Obviously, slow tapering, like reducing dose by 20% every 2 to 3 weeks, which is ideal. But it is completely depend on the scenario, at what purpose the patient is taking the medicine. Patient related factors are also playing huge role here, right? Also, the strategy includes switch to longer acting the benzodiazepines, for example, diazepam, if needed for the soother tapering. Okay, and non-drug alternatives are also there. For example, we have that CBT, the therapy which is behavioral therapy, right? So that needs to be introduced in cases of insomnia or sleep hygiene education if the patient is already stable but having minor, disturbances with it. So that is no need for benzodiazepines here. So in that case, you need to understand whole theory, and you have to remember those things. But with the help of machine learning, on a single click, you will be having this charts on your screen. Okay, so here we have example that a 78-year-old man taking alprazolam 0.5 mg nightly for 1 year for sleep, and he has had two recent falls. So a tapering plan is initiated over 6 weeks with sleep hygiene counseling. Sleep improves slightly and no further falls are reported in the next 3 months. So that is the follow-up thing is written here. I am not going into that detail about the case examples, but I want to emphasize that these are the theory that needs to be understand and remember for a long time. But if you are having the artificial intelligence and machine learning with you in your practice, you can have alerts and you can have this kind of charts which is popping up on your screen. Okay, so let's understand what is the summary of the whole first learning objective is both of these examples reflect medications that were useful initially but becomes inappropriate in a long term. So deprescribing improves patient safety and reduce avoidable complication. It is very clear in our mind. So, but in that particular case, we need to implement certain tools and techniques, which is our topic to discuss further in the second learning objective. Also, we need to combine the tools and technologies with the clinical judgments, obviously, and patient involvements. Okay, these are the key to success in the deprescribing. So let's understand further what is the role of artificial intelligence and what are the different parameters here. So first, left side, top of it, you can see here the role of AI in healthcare is in medical imaging and diagnostics. Very, very important. So how it can help you with the medical imaging and diagnostic? So first of all, image analysis and pattern recognition is depend on AI, right? To detect some of the abnormalities like tumor, fractures, hemorrhages, we are using some of the X-ray techniques, computed tomography, right? We are using positron emission tomography, PET scan, right, for the cancer identification. Also, these are all because of the technology it is possible, right? Also, AI can highlight subtle changes, often which is missed by the human eye. So that is the first thing in the medical imaging and diagnostic. Second, automated reporting can be the tool which is being there for the with the help of AI in the medical imaging and diagnostic. So it is generates further the structured reports for you and prioritize the urgent cases as well. For example, some of the cases like stroke or pneumothorax, etc. Also, it can help you with the early decision, early disease detection. Because basically we can say it is identifying the signs of diseases like the cancer, Alzheimer, diabetic retinopathy at very earliest stages, which are the treatable one. Also, it can optimize workflow for you, the AI, right? In the medical imaging and diagnostic I'm talking about. So it can optimize workflow, like the shots of the, some of the very important cases you need to take first, reducing further the radiologist workflow and the turnaround time if it is a very crucial part. So in that particular case also the AI is playing a huge role. Second, we have here the role of AI in the medical research and drug delivery on the left side. So in the medical research, so research also requires some tools and techniques. For example, very important, drug discovery, right? So AI screens vast chemicals libraries to identify further potential drug candidates which are faster and cheaper for you. Okay, and it can give you the suggested alternative agents as well, which are worldwide available. So this is in role of AI in the drug discovery is very huge topic. Secondly, in the research, biomarker identification is a topic where the AI play a huge role. So it is analyzing further your omics data, genomics, as I earlier explained you, right? Proteomics. Also, we have the transcriptomics, metabolomics, some of the omics data for the disease marker identification. That where also the AI play a huge role. Also in the clinical trial design, like selecting ideal patient's outcome and optimize further the protocols using real world data. That is also the role of AI in the healthcare. right? So we have here, see, the third topic where the role of AI in the rehab is mentioned. So which is basically in the, personalized therapy plan, the AI can play an important role. So artificial intelligence analyze further the patient progress to tailor the rehab exercises, like what needs to be done. Also for the robotic assistance, AI is powered by this particularly robotic assistant. It is very novel and new upcoming things. We can have some of the points are, coming in the future as well, but trust me, it will be there in the next 2 3 years. It is not as far as 20 30 years. At what extent the AI is becoming a giant thing, it is very near in the healthcare system. It is by the 2 to 3 next years we will be having this in practice. So these are the things in the rehab where the AI is playing a huge role. Also to predict recovery, AI models are there, to forecast further the patient's outcome, to guide further the treatment goals. So this is very important. Also we have some of the role of AI in the virtual patient care. So this enable further remote monitoring, right, symptoms checking, and the chatbots which are available for support. You may be having idea of some of the softwares which are having a WhatsApp chat, right? So robot is there to chat with you. Some of the robotic systems are there. Some auto generated messages are there, which is now emerging. So also it is very important in personalized care, right? So it is improving access, efficiency, and continuity of the care. Also, role of AI in the healthcare, you can see here on the right side, it is in the patient engagement and compliance. So how AI improves patient engagement and compliance? By sending reminders, okay, by offering personalized health tips, by tracking adherence, and using some of the chatbots for continuous support. Also, AI has role in the administrative application. What it means? So AI in healthcare administration automates further the billing, scheduling, claim processing, procurement, data management, right? Those are the things can be, the AI can help you with these things, right? Reducing further errors also and saving your time too. So is at this extent AI is, very important, and it is heading towards the limit. So we need to understand that at what different aspect the role of AI in the healthcare is. So we have starting from the imaging diagnostic to administrative application. It is a very huge area where the AI is playing a role. Let's understand further some of the tools and techniques in the deprescribing and medication management. So tools which are being used is a stop and start criteria. So every slide of the deprescribing has it, right? So we have screening tools of older person's prescription, for example, stop, and we have some of the screening tools to alert doctors to the right treatment as well, which is a start. Right, we have the Beers criteria as well, and this Beers criteria is for potentially inappropriate medication use in the older adults. I hope now you have idea about the Beers criteria. Okay, it is for potentially inappropriate medication use in particularly older adults, which is developed by the AGS, that is the American, the we can say Geriatrics Society. So that is AGS, and list of potential inappropriate medication in older adults it is showing you. Also, we have some MAI, that is a medication appropriateness index, that is evaluating further the 10 different aspects of prescribing, appropriateness. For example, some indication, effectiveness, dose, and directions. It is very least in use, but Beer's criteria and the stop start are very widely used. Okay, so you need to understand we also have some of the other things like a med stopper. In upcoming slides, we have. So also we have a comprehensive medication review, which is a CMR, which are the structured review done by the pharmacist. So I think in daily practice we have already doing it, right? Comprehensive medication review. Also, we have some deprescribing algorithms. So drug specific pathways are there for statins, antihypertensive, antipsychotics. If you are going with this medicines, you need to see some of the drug specific pathways. If you want to deprescribe it, what it would know how to proceed further. Also, if I already tell you about the Med Stopper, so that is nothing but an electronic medication assessment tool. Okay, EMAT. So that is electronic medication assessment tool. You can see here the name, medication assessment tool. The tool which is useful in the medication assessment electronically. Okay, that is the definition of med stopper, which is based on the, which is based from Canada, and it is shows the benefit versus harm in an interactive way. So basically, this med stopper is a clinical decision support tool designed to help the healthcare providers safely deprescribe medications, especially in the older adults with the polypharmacy. Let me just brief you about the key features of this, med stopper. So it is apply the stop and start and bear criteria in the inbuilt software. Also, it is ranking the medications by what it at a high risk, what is it the benefit, and how to the do the symptom control. Okay. Also, it can suggest which drugs to taper, stop, and continue. You can imagine the level of med stopper, right? So it can suggest that which drugs needs to be taper, stop, and continue, and it is also offering some of the tapering guidelines to avoid withdrawal effect. So if it is a medicines like benzodiazepine, or if it is a medicine like some of the very prolonged time if the patient is receiving, so in that case tapering guidance is also available on the software itself. So this is med stopper. Also on another hand, we have a med safer as well, which is the second one. See here the tools and techniques. So now we are moving forward with the techniques which are emerging further in the same trend. So the techniques are sharing further the decision making with the patients and caregivers, right? Gradual tapering and monitoring is a technique again. And use of interdisciplinary team. So that cannot be achieved by the single person. We need a whole multidisciplinary team here. For example, pharmacist, pediatrician, nurse, etc. to achieve these techniques in a real life, right? Let's understand one clinical example to better relate with these things. 80-year-old patient was taking 9 medications. You can see here the bold words, including benzodiazepines for sleep and iron supplements without evidence of deficiency. Using further stop criteria at a med stopper tool, okay, which is a software. So when you enter the prescription into the software, it will give you the suggestions of stop this thing if it is not recommending, okay, or if it is not useful enough in the particular patient. So clinicians identified this as a potentially inappropriate, right? So what is the action? Benzodiazepines was gradually tapered to reduce the fall risk and the sedation, and iron supplement was stopped again as the lab values were totally normal. Okay, so these are the case. But let me tell you the drug interaction. Some of the drug has tendency to lower further your or imbalancing further your normal physiological things. So in that case, we need to think differently. So we cannot 100% going with this particularly AI and machine learning suggested data. So that's I think I already give you the disclaimer that we cannot 100% depend on these things. Many factors are there, patient related, maybe disease related, maybe drug related, which is interfering with the prescription chart, right? So what is the outcome? The patient showed improved alertness, better mobility, and fewer daytime falls over the next 2 months. So the observation was done, and this is the outcome which was suggested by the MedStopper. So this case shows how deprescribing can enhance both the safety and the quality of life in the elderly patients. So this needs to be understood by you. Now I would like to request you to go through with this 2-3 minutes of video to understand how exactly this software, the mat stopper, is working, right? So this is very important to understand schematically that how exactly it is being working. Just have a look on the video.
Hi GP learners, welcome to another episode of Tip Thursday. Today I want to show an interesting website called MedStopper. So this is accessible from our resources general page from the website. As you can see here, when you click on it, first thing I'll ask you is actually whether the patient that you're talking about is frail elderly. This is obviously relevant for clear reasons, because this website is about trying to help you stop medications and what way to do that. So simply put, click whether they're frail elderly or not, enter the name of the drug. So for example, if we go for pregabalin, a common medication that may be used and may not be appropriate for long-term use, whether indication for using it, add it on, and it gives you a nice little summary of the priority of stopping, how it may improve things, whether it is an impact on future health, whether it can cause harm, a structured way of trying to reduce the medication, and also the implications of doing so in terms of symptoms. And I also mentioned something about the stop criteria, which I'll come to in a second. You can then add on all the medications that the patient is taking and develop a plan, as you can see here. So, for example, I've got a patient taking multiple medications like pregabalin, buprenorphine, paracetamol, American-based, so it mentions acetaminophen and zopiclone, and it gives you the priority in terms of how you do that and information on how to do it. I mentioned the stop criteria, so it gives you information as to how to do it and in terms of the implications, again, in more detail. And the benefit of this is that you can then print it off for the patient. So clicking here prints off a plan that you can give to the patient and hopefully get them on board in terms of the appropriateness and why these medications sometimes do need to be stopped for the overriding benefit and holistic care of our patients. I hope you found this website useful. I use it quite a bit, particularly working in the city Nottingham and stuff. And then we have obviously a lot of complex patients. Give it a try. Let me know what
You can see here the print option is also, here to download this and printing it, right? Here they are suggesting also the stop and start criteria, like what needs to be done in the prescription chart. Here they are showing the may improve symptoms, may reduce risk for the future illness, and may cause harm. The emojis here elaborating the whole things. Okay, if you want a approach like how to go with the taper approach, it is in descriptive form, it is available, and possible symptoms when stopping and tapering is also written here. So everything is available on a single click, which is like just putting your prescription into it and it will generate the whole data for you. So this is how the software is working. You can also try this if you want to reduce the polypharmacy. Right. So these are in practice, and this is not as widely being used. But as I earlier said, you cannot completely rely on this particular things. But they are having the confidence that it is showing the best possible things, and it is a AI generated things, and the accuracy is very very high. Okay, so these are the software which is in the practice nowadays. So why this video actually works? So basically, it demonstrates you the real-time interaction, like searching for the medications, assigning the conditions, and generating a de-prescribing plan as well. It highlights further the risk-benefit ranking, like the red color is a stop first, green is the least urgent, right? And provides a tapering guidance as well, as I elaborated in the table as well, as it in itself, right? It shows also how clinicians can print or export the plan for a patient's discussion as well. So everything is available on a particular chart, right? Particular click, I can say. So what is the exact role of artificial intelligence in medication management? So what AI can do? It can actually identify some of the PIMS, that is potentially inappropriate medication. Also, it can predict adverse drug reaction and support the clinical decision making, right? So everything is integrated. Everything is integrated into one single platform, and that is nothing but the artificial intelligence. Let's just move forward with the another topic, that is the potential applications of artificial intelligence, in which things we can use these things, right? So for detection of drug interaction, you can use for monitoring medication adherence, for predictive analysis, for personalized treatment recommendation, optimizing medication, remote education and telemedicine, predicting of adverse drug reaction, some of the real time support for decision making, and designing clinical trials. In every aspect, AI is playing a huge role. I think this charts is a very explanatory, and it is very easy to understand at what extent the AI is making a difference in everything. I think for Okay, I hope my screen is visible and I am audible to you.
Yes, ma'am, you're audible.
Okay, so these are certain potential applications of artificial intelligence in different streamline, right? And we also have personal experience with detection of drug interaction, some of the prediction of adverse drug reactions which are associated with our specific treatment. Okay, so we are also having dependency on the softwares. So, what is the application further? In clinical decision support system, integrating further electronic health records to give us the real-time alerts. Like for example, we have alert for NSAID use to the CKD patient. Also, we have some of the natural language processing, for example, extracting unstructured medication data from the clinical notes. That is also the application of artificial intelligence. Also, for the predictive analytics, like AI models can predict who is at a higher risk of polypharmacy related hospitalization. And also for the machine learning algorithms, like to analyze the patient history, the labs, and the medication patterns to recommend further the deprescribing. So we have different tools and techniques, we have different platforms, we have different softwares which are aligning with our management of the polypharmacy, right? See these tools using AI. We have a MedSafer here. MedSafer is also based on Canada, which is an AI tool analyzing electronic health record data to suggest deprescribing opportunities. So MedSafer is again a clinical decision support tool that is helping healthcare team to identify and safely deprescribe potentially inappropriate medication in the older adults. Okay, by generating some of the personalized, very evidence-based alerts and the tapering guidance that is also gives by the MedSafer. Also, we have the taper, that is a team approach to the polypharmacy evaluation and reduction. Okay, that is a combines clinical input and AI tool. It is a combination actually, and it is also a deprescribing approach that combines clinical expertise with the AI tools. Okay, to review further the medications, also to reduce inappropriate prescription and to improve the overall patient outcomes, especially in case of older adults. So these two are the tools which are in very large use, right? MedSafer is very important to understand. See here, the AI in the drug development is also making a huge impact since finding the hit or the late synthesis of the drug-like compounds to the drug approval and the drug repurposing. Every aspect of this has the role of AI. Now, so we have a drug discovery. I already explained you what is the role of AI in the drug discovery, right? Trial also has the role of AI because we need some of the hypothesis or some of the real evidence-based data happening worldwide. And what is the clinical scenarios? What are the results associated with it? We need to understand these things, right? Before initiation of anything. So that needs to be understood by the researchers, and at that time, AI and machine learnings, playing their huge role. Challenges and ethical consideration. Let's just understand challenges and ethical considerations which are associated uh, with our AI and machine learning. So we have first, that is data privacy and patient consent in AI tools. As I earlier said that that is there are some of the challenges in the electronic health records, and that is the data integration. We need to have a large huge storage, and also privacy should be associated with the same thing, so that the data cannot be misused. Those are the things, and with that we need to have this kind of solutions and consideration while implementing these things in a practical setting. So data privacy is a huge thing, and patient consent also, because we are we need some of the information which are patient specific, and we need to integrate into our system, so we need to have a consent also. That is the challenge. Second, we have over reliance on algorithms may overlook the patient preferences. Maybe this may be the option that that might be arise as a challenge also in a long run, right? Also, we have a challenge that is need for validation of AI models across different population. So we required a validation for it, and integration with the clinical workflow is still in the evolving phase. So this is very important to understand that there are some of the legal, ethical, social challenges in implementing artificial intelligence and machine learning in our daily life, right? Daily practice actually. So these are some of the challenge, and these are some of the schematic presentation you can see here. On the left side, we have some of the ethical things, like we need a regulation, we need a privacy, we need a mitigation of bias, transparency and relevance. And on the legal things, we have to have governance, confidentiality, liability, accuracy, and some of the decision making, some of the decision making, we can have guidelines and some of the legal things like a law to protect some of the data. So if you know, the HIPAA is also there, which is the protection law in the United States, right? So these are the already in the developed countries, they are having some of the laws to protect the patient data and integration. And that's exactly where they are playing, they are having the same, system of electronic health record, which further helps physicians in the clinical decision support. So in our country, we don't have that kind of legal things with us, but it is in pipeline, we can say, because everything is emerging nowadays, and healthcare is moving towards its limits. So basically, we are also expanding and we are also evolving. So in next 5 years, I think maybe we have the same data protection laws with us, and that time we think of integrating some of the genomic data as well as some of the patient related data, which might get interact with the electronic health records. And at that time, we can proceed further with the highest use of AI and machine learning, right? So we have here the real world case example to understand. We have three example basically. First is the AI driven tool in the geriatrician ward. So if we are implementing it, the outcome will be very, very large, right? It can actually reduce 1.2 meds per the patient. So it is decreasing ADR by 30%. So that is AI driven suggestion that might help us to understand how exactly it is in a real case, how it is helping. Also in the hospital, CDSS for the high risk meds, if the patient, if the system is enabling and if the system is in working, there might be giving you the alerts which are triggered in the ICU setting, which is led to the real time discontinuation of the inappropriate sedations. Okay, so this is again a very important thing. And med safer pilot study is also suggesting that it is used in the long term care. Clinicians are also accepted 60% of AI deprescribing recommendations. So pilot study has that result. So these is the real world case examples, and we need to understand that this is our future, right? So we will be having those kind of things in our ward rounds and healthcare settings to practice further. So this is very important. So what are the points to take home from this particular session is deprescribing is a core strategy in the rational medication use. Also tools like this stop start criteria, some of the Beers criteria, and Med Stopper. The software provides evidence-based guidance to you. Also, artificial intelligence enhances further the decision making by analyzing large data sets and predicting risks. Also, successful represcribing involves patient centered care, clinical judgments, and appropriate tag integration. So, that is the overall summary of the session. Also, I would like to remind that while AI and machine learnings offer very powerful support in the clinical decision making, we cannot rely on them entirely for the treatment approaches because it is dealing with the human, right? So these tools should be seen as a valuable adjuvants, as I earlier explained you in the beginning. It should not be used as a replacements. Okay, it is a adjuvants for the clinical judgments, obviously, and they can help to save time, enhance efficiency, and it is offering the data driven insights. But final decisions must always consider individual patient on the individual patient context and clinical expertise physician and a pharmacist is having. So when it is used wisely, your AI and machine learning can indeed bring the additional positive impact to our daily practices without compromising the human touch in the healthcare. So that is the conclusion of our whole the theory. So you need to understand that it is an adjuvant, okay, not a replacement. Okay, so that is the end of the session. I think we can move forward with the question and answer.
Sure, ma'am. There are some questions here. The
Yes.
first question is if there has been any recent involvement of AI to solve the phenoconversion problem related to pharmacogenomics and personalized medicine.
Can you just repeat it? Just give me a minute. I can just read it from myself.
Yeah, sure.
Genomics, right?
Yeah.
Am I audible to you? I think there is network problem from my side little bit.
No, you are completely audible.
Okay, so the very first question I can see here that since you mentioned genomics, I wanted to ask if there have been recent involvement of AI to solve the phenoconversion problem related to the genomics and personalized medicine. Yes, there are certain emerging artificial intelligence tools in the genomics to solve this problem, which is a very huge because genomics itself it is a very new and novel thing to us, and it is emerging in the existed situation where we only have the genetics with us, right? And genomics is very important tool to understand, and it is very important in case of personalized medicine. So yes, the answer is yes, AI is solving the problem associated with this. How can we monitor and manage withdrawal effect of the disease relapse during deprescribing process of medication? See, you cannot always get the exact, the like a bullet points like this might be arise, but it will give you the brief overview that these might be the risks of the deprescribing that needs to be monitored by you. And the AI software also suggests monitoring tools as well. So it will suggest you going with the LFT, RFT, CBC, what needs to be monitored afterward if you are going with the deprescribing. So the software is suggesting that. I think in the video which is shown in the PPT, that is clearly demonstrating the things. But I think it is, if you can personally click on the MedStopper and if you can you visit the website, you will have a clear idea what exactly they are suggesting. Okay. So it is nothing like for a specific thing, it is showing you the bullet points, but it will give you a brief idea about monitoring afterwards, what needs to be monitored if you are going for deprescribing. Okay, next question. Which
Yeah,
date?
sorry to interrupt, ma'am. This would be our last question due to some time constraints we have.
Okay, no worries, no worries. I can understand totally.
Yeah, so we can take one question and then we'll end the session here.
Sure, sure.
Well, the question is, how transparent is AI algorithms decision-making process? Can we understand the reasoning behind its recommendations?
Okay, so see, we cannot completely rely on this thing. So we cannot say that it is, 100% transparent, but the software is suggesting and software is whatever the data is suggested by the software, they are having the importance and they also have that particular, the reference codes. So that is because of the hypothesis and whatever evidence-based flow ups they are monitoring. So it is important to check in the reference also that what needs to be done afterwards in a very crucial cases, right? So the transparency is, we can say it in between of 80 to 90% in the healthcare setting. So we cannot completely rely on, but obviously we can take the help of the machine learning to pick up our next role.
Thank you very much, ma'am. Now,
Thank you.
we'll just click a picture. So everyone, please turn on your cameras for a quick picture. Yeah, thank you, everyone. Thank you very much, Dr. Neha ma'am, for this eye-opening session. It is amazing to see how technology is supporting safer and smarter medication decisions and transforming the way we approach prescribing. Now we will move to the final scientific session of RAMCON 2025. And what a better way to end this by bringing the spotlight back to where it truly belongs, the patient. I mean, that is the main reason we are all are here as healthcare professionals, right? To optimize patient care. The topic for this session is patient-centered deprescribing across the continuum of care. This topic reminds us that deprescribing is not a one-time clinical task, but a dynamic, ongoing process that must adapt to the patient's need across hospitals, homes, and communities. Delivering this talk is none other than Dr. Akhila Reddy Jallela ma'am, a passionate healthcare professional with doctorate in pharmacy. She is the head of Department of Clinical Pharmacy and Drug Safety at Wellness Hospital, Hyderabad. She is also a NABH accreditation consultant and AI-enabled healthcare innovator. With her vast experience in both systems and patient-level care, she will be guiding us through how de-prescribing can become more holistic and truly patient-centered. Over to you, Dr. Akhila, ma'am.
Hello everyone, good evening to all.
Good evening, ma'am.
Can you able to see my screen?
No, you haven't shared your screen yet.
One sec. Is it visible?
Not yet, ma'am.
One second.
I think it will take some time for ma'am to share the screen. Till then, stay tuned until ma'am comes back. Yeah, she's here.
Yeah. One minute.
Yes, no problem, ma'am.
Okay, okay. Full screen चाहिए. हाँ. Yeah. Is it visible to everyone?
Yes, ma'am, it is visible.
Yeah. Hello everyone. Today's topic is patient-centered de-prescribing across the continuum care. So this is completely different and where we have to be very careful when we are dealing with the patient. And you are expertise in medicine and you people are going to de-prescribe the medicine where it leads to to ensure safety to the patient. How and when and where it when de-prescribing can be done and where it can be applied, where we are going to see the real-time case studies today. Aging populations, chronic diseases, increasing polypharmacy. In India, almost 1 in 3 elderly patients on more than 5 medications. Polypharmacy is not equal to inappropriate always, but when it is, we must act. deprescribing is equal to key to rational medication use. These always state a quotation that more is not always better, especially in medicine, where it is where it is supposed to be restrict the irrational use of drugs, where polypharmacy included, and most of the chronic diseases patients like oncology and psychiatric patients, Parkinson's, in many diseases, chronic diseases, there will be a polypharmacy and can be done, deprescribing can be done. For example, if we take the Parkinson disease, what is Parkinson disease? That is a brain neurodegenerative disease when it dopamine decreases in the brain. If we did not monitor the medicine continuously and the dopamine increases, then dopamine leads to the psychosis. So that is the reason dopamine is always to be balanced at the same time, and it should be, the dose should be monitored, and the supportive treatment can be monitored always, and the deprescribing can be done after a couple of months, not immediately. Then actual, what is deprescribing? Let's see the definition today. Deprescribing is the planned and supervised process of dose reduction or stopping the medications that may no longer be beneficial or may be causing harm. If we take any medicine in the chronic disease, it might be suppose antibiotics. There should be for sure that monitoring should be there in the rational use of antibiotics. So though the symptoms are subsiding and the antibiotics are continued, then it may cause to the patient, and which may really leads to the resistant or sensitivity to the patient, especially higher in antibiotic, and at the same time the high risk drugs also. So what are the goals to deprescribe the medication in practical day-to-day life? When you are dealing with the patient, what are the terms to be monitored and how it is monitored? Let's see the today. What are the goals? Optimize medication use, improve the quality of life, reduce adverse drug events and pill burden. What is the scope? There is only three scopes where we cannot decreases we cannot do the deprescribing in generalized diseases like a regular alcohol withdrawal syndrome or regular disease. It can be done especially in the three situations. There is a scope, that is a chronic diseases as we discussed, and palliative care, and the post discharge transitions. So deprescribing is reducing the drugs, and which may leading to the continuous harm to the patient. At the same time, it is duplicating the drug. And if we check the continuum care of deprescribing fits, what is the flow and how it can be applied? Continuum care is equal to the lifelong journey. What is continuum care actually? A care of the patient, it should be monitored with a consistency. In the primary conditions, the medicine will be huge number around 20 to 15, and the secondary, tertiary, home care and palliative. These are the conditions, these are the situations where deprescribing can be done in the continuous journey of the patient chronic diseases. Deprescribing at key touch points, where it can be done in the day-to-day process in patient. During hospitalization, what we have to do? We have to assess the drug therapy change. And at hospital admission, see if there is a medication reconciliation to be done for sure when the patient is going to admit in the hospital. What is reconciliation? What is actual medication reconciliation is, we have to check any past history of the patient, and we have to monitor the medication and the doses of their self medication, and we have to reconcile. That is actual reconciliation, where the past history and the previous medication to be checked by the exclusive clinical pharmacist, because doctor may not ask. Doctor may ask only what are your history. You might be having diabetic. Are you diabetic? Hypertensive? What is the duration? What is the level you get? What is the dose you get? But they don't do the reconciliation. The actual person medication reconciliation to be done by the clinical pharmacist only, and the doses can be adjusted. At the same time, the duplication of the drug can be preventable in the during this process. During hospitalization, assess drug therapy change. Whenever you hold the case sheet, whenever you check the case, there will be a repetition of the drugs, especially antibiotics and especially multivitamin, and there are high risk medication included too. See, if you go through according to the dosage regimen to the patient, whenever the patient is hospitalized, the broad spectrum antibiotic will be given to the patient. The ceftriaxone is the common drug where we use, where it works for the positive organism and the negative organism. After identifying the specific organism, then the specific antibiotic will be given to the patient without subsiding the previous antibiotic dose. There is a scope where you can do the de-prescribing by assessing the drug therapy. And whenever you go to the daily ward rounds, you have to check the treatment chart for sure. The list of drugs should be monitored by the clinical pharmacist, because you people are expertise in medicine where the doses can be adjusted, where de-prescribing can be done, and what is the mechanism of the drug and what is the impact of the drug on the patient, whether if it is impacting to the any investigations, or else if it is creating any known errors or adverse drug reactions, then we can de-prescribe it immediately. And at discharge, usually at the discharge also there will be a lot of duplications. Calcium, especially multivitamin with the protein powders, and sometimes antioxidants also leads to something toxic to the patient condition. So we have to monitor the patient while counseling the discharge medication to avoid duplications. And follow up in the OPDs or telemedicine. Usually in the OPDs, without checking the previous medication, without adjusting the previous doses, and without medication reconciliation, the medication of the current complaints will be prescribed by the doctors. Then we have to review what is the ongoing need, what is actual problem to the patient, why he has come to the OPD, and if it is recurring, if any disease is recurring, why it is recurring, is there any suspicion on the drug. In such a way, you can do the de-prescribing as well. And at the same time, home-based care. Monitor adherence and new symptoms. During rehab, in neurodegenerative or any CVA condition, then home-based care will be taken. How can you monitor the patient during home-based? Can anyone say? Usually whenever patient is on home based care, the patient will be on the listed medication, but we have to monitor the patient's symptoms. That is, if any new symptoms are developing or any existing symptoms are subsiding. If any existing symptoms are subsiding, then immediately consult your respected doctor, and immediate correction to be done, where multiple drugs and the polypharmacy may lead to the harm the patient. Already patient is on a condition where he is about to get into the palliative care, then we have to reduce the polypharmacy, especially on the bedridden patient. Why? There will be a drug interactions, there will be a food drug interactions, there will be a adverse drug reactions where we could not identify the internally. The usually ADR can be monitored uh, if any it is something physically, or any rashes or any some other convulsions to be there. But if you take the condition of the polypharmacy or home based care patient, there will be internal degradation of the organs, due to the long-term usage of the higher-end antibiotics and higher-end dosage of the drugs, and including antioxidants too. So, based on the de-prescribing the codes, we have a code that every healthcare encounter is an opportunity to review medications. Where it cannot be done, it won't be done in the day-to-day practice, where we don't even have thought to reduce the medication, because this to be monitored for sure, which may prevent harm to the patient, and we can ensure the patient safety as well. So every healthcare is involved. Pharmacist can do it, nurse can do it, paramedics can do it, clinical pharmacist can do it. But to review on medication and to specify any drug or to adjust any dose, the clinical pharmacist plays a key role, as they are expertise in the medications. But to review all the medications, to know about the mechanism and the classification of the drug, any healthcare can review the medications, and they can escalate it to the next level to prevent the polypharmacy, and they can do the de-prescribing as well. So patient-centered de-prescribing. So what we have seen till now, how de-prescribing can done and how continuum care can be centered, and we have seen all these things. So how it can be related to the patient-centered? De-prescribing that respects the patient preferences, values, goals, and informed choices. See, we have to monitor the patient present illness and the chief complaints and the past history too. And the key principles to follow is shared decision making, informed consent, therapeutic goals alignment, cultural sensitivity, communication across teams. How these 5 points are included? Shared decision making. See, if a consultant or any healthcare professional is supposed to add some medication or to decrease the doses or to increase the doses, the decision make whatever the decision has done by the particular person, it should be shared to their co-workers, because they are treating on some other symptom. If you take the general physician, he is treating some generalized disease, but he has referred to the neurologist. So whenever the dose or drug can be adjusted, that is supposed to be adjusted by the general physician, it should be shared with the neurophysician, where he is also a co-worker on the patient. So that is the reason their information to be shared on the patient medication, on the patient information too. And the informed consent, we have to take the consent from the patient when we are giving the high risk medication, antibiotics, benzodiazepines, and the narcotics. And therapeutic goal alignment, how therapeutic goal alignment can be monitored. If we take the chronic diseases, always it might be duplication can be done, drug duplication, especially in the therapeutics. So whenever the medication list is extending, we have to go for the therapeutic usage of the medicine and mechanism, especially the mechanism of the drug, and with the list of drugs which is leading to the drug-drug interaction, and the duration of the medication. See, if the antibiotic is prescribed at 8 a.m., and some other, if we take the piperacillin tazobactam and if we take the vancomycin to the auto patient, those medicines cannot be given at a time. A certain period of certain duration should be maintained between the drugs. So their alignment should be, the therapeutic usage of the drug alignment should be always adjusted whenever the multiple medication are prescribed to the patient. And the cultural sensitivity, see, that is the most important. If a patient is on the same antibiotic, especially on the higher end antibiotic, for a long duration, especially 10 days, then the culture should be sent to the lab if any culture sensitivity has developed to the patient on the antibiotic. Or else can we monitor with the same drug, or else can we take some antibiotic and we can monitor with the same drug, or else can we take some antibiotic and we can monitor with the same drug. I'm so sorry. There is a power cut at my place. I'm sorry.
It's okay, ma'am. Would you be able to continue with the presentation, ma'am?
Huh. So we have to check whether the drug can be continued or the if any new drug to be added based on the investigation. Huh. Is it audible?
Yes, ma'am, it is audible.
So the first and the foremost thing, and it is a mandatory thing, the people who are working in the healthcare setup, this is mandatory and in the healthcare professionals, and it should be monitored by the clinical pharmacist only. The communication across the teams, especially nursing, paramedics like respiratory therapist and physiotherapist, and at the same time the consultants too, and physician assistant. Communication across the team, that is most important to whenever we are dealing with the patient directly. This is most important to be monitored by the clinical pharmacist who is responsible to the patient care from the date of admission to the discharge counseling. If communication is lacking, there will be a continuous lack in the treatment, and which may lead to the harmful to the patient, and it may not all the symptoms may not be addressed whenever the patient is hospitalized. So how communication is important across the teams. Nursing, if we take the insulin chart, whenever the communication was lacking, if they don't communicate in the handover, then the next shift of the nurse, or else next shift of the physician assistant, they cannot know the actual condition of the patient. And if any patient develop adverse drug reaction in a particular duration, that should be written on the case sheet with some labeling on the top of the case sheet that patient has developed ADR on so and so time. If a patient has developed with a patient is diagnosed with a cellulitis, and if the patient is has developed the ADR with the antibiotic, then immediately what is the time and when it has developed and how much time it took to re-challenge, or else if any positive de-challenge has been done on the patient, everything should be documented. The communication across the team is a documentation. They cannot speak verbally as they involved into the multiple patients. It may lead to the lack, or else they may forget individual patient to patient. So documentation is most important. Where the point why I mentioned clinical pharmacist role is very important is the documentation should be monitored by the clinical pharmacist only. Whenever you people go to the rounds, you have to check the condition of the patient. Whenever you talk with the patient, you'll come to know what is the condition, actual condition, and if whether it is treated or not, whether nursing care has been taken or not. So you people can know better in a better than other departments whenever you deal with the patient. So you deal with the documentation, case sheet, that is case sheet, and you deal with the patient. So the communication across the team is most important. That is through the documentation, which may ensure the patient safety, and it may ensure the things for the deprescribing, or if any drug interactions, if any adverse drug reactions, if any medications errors are developed, then everything should be documented. That should be monitored by the clinical pharmacist only. And whenever you find something lacking, you have right to raise the voice. You can issue any medication error form with the kappa and all those things, and it should be addressed immediately, and they cannot remain same. This is most important whenever you are working with the human directly with the patient. We if we work with the data, then it won't affect anyone else. Whenever you are directly dealing with the patient, this is most important. And at the same time, the discharge, during discharge, everything from the date of admission to the date of discharge, it includes everything. So during discharge counseling also, you can monitor all the medications, all the clinical condition of the patient, whether it is treated or not, whether therapeutic goals are aligned or not, drug interactions are observed or not, dose adjusted or not, all the past history and the complaints, adverse drug reactions, medication errors, that can be monitored by the clinical pharmacist during discharge counseling also. So if any communication across the team is lacking during the hospitalization of the patient, that should be addressed by the clinical pharmacist. And there are some tools. See, you cannot deal with the case sheet directly. You are when you are in the hospital, there will be a huge occupancy, and you cannot remember all the condition of the patients and every related drug related problem of the patient. So you do need some tools, you do need some documentation data. So there will be some tools, like as you have heard in the previous session about the AI and few tools. There are few tools, and which can be practiced by the clinical pharmacist. That is BASE criteria, stop and start, medstopper, farm acronym. Medstopper is a software one, but stop and start and the BREEZE criteria can be applied directly on the patient whenever you are monitoring the patient, whenever you are dealing with the patient. Farm acronym also, you can, this is not actual tool, but you can apply this tool as a few points like checkpoints. That is P as a patient values, H as a history, assess risk or benefit, review regularly, and monitor outcome. These this tool can be applied during the discharge of the patient, and whenever the clinical conditions are subsided, these tool can be used by the clinical pharmacist. See, there are challenges and solutions. Whenever you are dealing with the patients about the deprescribing and the continuum care, you may find some challenges. Then to whom you are supposed to approach, and you cannot be responsible for entire patient care, right? So all the departments in the hospital, you can make them accountable, you can make them responsible when you are finding the challenge. So what are the challenges and solutions we can discuss now? What are the basic challenges you may get day to day? Patient fear of stopping medications. See, whenever you are dealing with whenever you are dealing with the medications and whenever you are counsel the patient, if you tell them directly you stop this medication, how do they react? So usually there is some steps to counsel the patient. You have to deal with the patient with empathy. You have to introduce yourself with empathy, and you have to address them with their names or any relation so that they'll feel comfortable. And you are going to describe the condition of the patient. The vitals have been developed during hospitalization of any, if any clinical conditions has developed something critical, you are going to describe in detail. So it's high, then they listen to you because you got connected and you made them comfortable with their empathy. In such a way, you have to educate with empathy. Whenever you deal with the patient, empathy is mandatory to maintain. So before going to the patient itself, you have to monitor the complete case sheet of the patient. You cannot counsel wrong details to wrong patient, right? So before going to the particular patient, check the patient case sheet, check entire history of the patient case, and what is the critical condition has developed, what are the symptoms during hospitalization, and after 5 days, and what are the drugs involved, and what are the investigations done to the patient. These are the key factors whenever you are going to, before you are going to the patient. So when you cannot deal with the patient direct clinical condition, so introduce yourself and make them comfortable, and slowly then you describe the disease. These are the things you got it. And with the present illness, these are the illness when you are hospitalized to the patient. Whenever you hospitalize the patient, these are the medications will be monitored. If any adverse drug reactions are developed, then you have to tell the patient that if any drug interactions with, suppose if patient has developed adverse drug reaction with the pantoprazole, make the patient remember the drug name, that this is the pantoprazole, this is the proton pump inhibitor. You got adverse drug reaction. Whenever you go to the hospital, whenever you visit the doctor, you try to convey to the doctor that you cannot take these drugs because you got adverse drug reaction in hospital when you got hospitalized with the condition so and so condition. So you have to educate all the details of the patient and the clinical condition of the patient, and in further condition also, if they have developed any areas, make sure the patient to be remembered all the things, all the clinical conditions, and what are the treatment as given to the patient. And next, lack of time in OPD. So you cannot deal with the IP patients and OPD also. You cannot stand in pharmacy, OP pharmacy, and you cannot deal with the patient directly. Whenever the pharmacist dispense the medication, you cannot counsel. You are busy in the discharge counseling. So how you are this is one of the challenge in day-to-day practice. What you are going to do, you are going to use the pharmacist. Pharmacist will not describe the medication like a clinical pharmacist, but they can give a quick review of the patient, when to take, how to take. The mechanism is always be told by the clinical pharmacist only. And the next challenges, if you take the condition, multiple condition of the patient, then multiple consultants, multiple physicians will be involved, where they get into the multiple prescribers. Then how can you coordinate? You can coordinate with the via EMR. See, when EMR used, usually when the patient is hospitalized, or else whenever they come to the hospital with OPD or IPD, then you are going to check with the EMR, and you can coordinate with the or the telecall also. So the like kind of front office or front office people or PREs, you can ask the people to get the patient data, and which may helpful for you also. And the resistance from caregivers. How? See, you have to counsel the patient, at the same time caregivers also. When this fourth point is included is home-based care and palliative care. You have to share the risk and benefits of the drugs very clearly to the attenders, so that whenever whenever they take care of the patient, in that process, if they find any changes, so that they can come to hospital, or else they can visit, or else they can take any teleconsultation to the doctor, and it can be subsided immediately. So these are the four things you are going to face the challenges, and at the same time the strategies how to overcome all those. So next thing is the tools. Whenever we cannot take the deprescribing decision, what you are going to do? Whenever you are going to unable to take the deprescribing decision, you have to check the multiple drugs mechanisms. Firstly, check with the classification of the drug and the mechanism of the drug. If any mechanism, or else if any classification drug and the mechanism is duplicating, then apply this tool that you have to deprescribe the one of the drug among the list of drugs. That is a key point. And the next thing is, whenever you educate the caregivers, they do give some information about the home medication or else any self medication. Then that is the one situation where you can deprescribe the drug. So here are the very key takeaways, and let's take action. How can we take? Deprescribing is not a withdrawal. It is a clinical optimization. See, as I told you just now, that classification and mechanism, when it is duplicate, when it is overlapping, you can deprescribe one among the list of the drug. So it is a clinical optimizing. It's not a withdrawal. Whenever you withdraw entire mechanism of the drug and which will be very useful to the patient, you cannot apply this one. But it is not at all a withdrawal. Deprescribing is always a clinical optimization, which may lead to the patient harm with the drug-drug interactions, adverse drug reactions with the polypharmacy, or else unnecessary mechanism, unnecessary therapeutic duplication. And it must be continuous, collaborative, and the compassionate. Empower patients, educate caregivers, engage teams. The art of medicine is not just knowing what to prescribe and what to unprescribe and when. As we discussed till now, the medication can be prescribed by the consultant, that is physician. And the decision about the deprescribing can always be done by the clinical pharmacist only, because they knew well about the drugs, about the therapeutic classifications, mechanism, and the administration. Every part of the treatment can be educated by only clinical pharmacist. So only the consultant know how to prescribe the medication, but how to deprescribe the medication is the better person and the best person is always a clinical pharmacist, by using certain tools. How you have to use the tool and all those things, we can check the situations and when to use and how to use. See, whenever the therapeutic duplication is one of the key point, and if patient is on the same medication, that is without any medication reconciliation. When if the patient is on zinc COVID, and at the same time zinc also. See, zinc will be always 50 mg in zinconia. So whenever the therapeutic duplication is going on with the antioxidants here, so you are the decision making how to deprescribe it, how to deprescribe, whether you have to deprescribe the zinconia or zinc COVID. You have to check the patient condition. What is the condition? If patient is under any malnutrition or any deficiencies, you have to go through the clinical condition of the patient before deprescribing the zinc COVID or zinconia. Then you are going to identify the drug or else the mechanism and the therapeutic duplication. Then you are going to optimize the therapeutic duplication of the drug, that is the zinc, if you take an example. So we have certain checklist. How to deprescribe the checklist? We have especially these are adopted from the WHO only. Base criteria and start criteria. These three tools can be applied in the healthcare whenever you are dealing with the patient. See, before applying these tools, you have to assess the patient. Confirm patient identity and age. Why patient identity is most important? Demographic details plays a key role. Both patients may come to the hospital with same name, but age might be different, or else sometimes patient age, gender, and the condition and the initial, everything will be the same. Then at that situation, what you are going to identify is MR number. Your MR number or UHID number. So always check the patient demographic details and at the same time MR number also. You have to check MR number and the patient details and the list of all the current medications. Either it is a current prescription or OTC or herbal or any Ayurvedic or else any self-medication. Identify the patient indications. What are the indications? Why medications are given? What are the current complaints? Take for the life expectancy, goal of care, frailty, and the oral palliative status. So how can you check all these things? In the chronic patients, chronic diseases, and the palliative condition, this you have to check the life expectancy. And if you take the condition of the patient or any cancer or else any breast cancer, go with the level, at what level the patient is. Is any meds were there or not? If any meds is there, then to what organ it is. If it is meds to the brain, you have the life expectancy for 2 months only. If it is to the breast, and if it is for the breast, it will be up to 4 months. So you do have some life expectancy based on the clinical conditions. And next is assess functional status and the recent hospitalizations. So how the condition and how it is the condition, how the status of the patient, functional status of the patient, if any recent hospitalizations are there, if patient, these fifth point can be applied during OPD patient only. So you have to assess the patient in this condition. Coming to the treatment part, are any medications no longer indicated? Are any drugs duplicated? Are any medicines used beyond recommended duration? Is there evidence or adverse drug reactions or poor adherence? Are any drugs contraindicated due to comorbidities? In the treatment part, these are the points to be supposed to be checked by the clinical pharmacist before deprescribing the drug. So this is the condition of the patient you have to monitor before applying the tool for deprescribing. So let's see, let's dive into the tool, how it is to be applied. Bees criteria. Bees criteria is especially used for the geriatric patients, that is above 65 years. So avoid long-acting benzodiazepines like diazepam, clonazepam, lorazepam, whatever the benzodiazepines are there. We have to avoid the long usage of diazepams and avoid anticholinergics. So we anticholinergics, to some extent it will be duplicated. Avoid slide scale insulin in non-ICU settings. So what are the slide scale insulins we if we check over there? There are human atropate, human atrat. There are so you can avoid one of the among that based on the patient condition. Use PPI short time only unless high risk. Limit NSAIDs in CKD, hypertension, and heart failure. So these are the tools applied in the geriatric patients, especially with the base criteria. And the stop criteria. Whenever you use the stop criteria, avoid duplicate drug classes. Here, classifications. As I told you in the previous slides itself, the classification is most important whenever you are going to avoid the duplication. Stop statins in the patients with end-stage dementia. Avoid antipsychotics unless clearly indicated. Reassess beta blockers in bradycardia or hypotension. Stop long-term benzodiazepines for sleep anxiety. Until unless if patient is having any specific condition, then give the benzodiazepines to any age of the patient. And start criteria is to ensure necessary medications aren't missed. Add ACE inhibitors for heart failure or diabetic nephropathy. Add biphosphonates in high fracture risk elderly. Add antidepressants for severe untreated depression. So this is these are the conditions where you are supposed to use the start classifications, whereas stop, you have to stop these classifications. This is a straight away principle whenever you are dealing with the patient directly. These are the 5 principles you have to apply. That is in any age of the patient. It might be geriatrics, pediatrics, or adult age. So these are the tools to be applied. And the patient involvement, how patient is involved in this. So condition, discuss risk or benefits. So whenever you deal with the patient, whenever you counsel the patient, or else whenever you counsel the patient, you'll be knowing all the observing skills, and the clinical condition of the patient, existing condition or else any previous conditions are there. You can analyze it, and you can analyze whether it is a benefit of continuing or stopping. So you have to discuss with the patient about their clinical condition in deep. And next is explore patient preferences and health course. Sometimes some patients may not like, or else they have some they have something decision, like the few people don't like to take calcium. So at that moment, then you have to, whenever you counsel with the patient, then that's fine, I'm not giving you the calcium tablets, you I can give you some other medication. You can counsel the patient and you can add on the multivitamin where calcium tablets will be used, so that psychologically patients may not be in a feeling that this doctor has given the medication which was not preferred by me. So psychologically they'll be stable that the preferred medication has given to me and it can be treated and my clinical condition will be subsided within no time. So we have to know the patient preferences, which is most important, and ensure shared decision making. If we are going to change any medication, as we discussed, based on the patient preferences, or else any based on the risk or benefits, or else any therapeutic duplications, or else therapeutic duplicating the mechanisms, so you will be taking some decision being a clinical pharmacist. You have to share this decision with the consultant. You have to discuss with them, and after discussing with them itself, you have to write a medication on the paper which has been changed by you. Address fears about withdrawals or condition worsening. Whenever you are withdrawing the medicine, that is duplicating, it might be anything condition, whenever you have withdrawal, or else you added some medication, or else which is worsening the condition of the patient, you have to counsel the patient. If we check overall the things which we have discussed till now, the counseling plays a key role. Every department cannot be done, especially nursing cannot counsel about the medication because they are good at administration, not in the counseling, or else they are not expertise in the medication. And physician assistant, they acts as a barrier with the consultants and the patient side. And consultants cannot counsel about the medication, they will counsel about the condition of the patient and the existing the diagnosis the patient. But the people who are going to take care of the treatment and the counseling is only a clinical pharmacist in a healthcare. So whenever you counsel the patient, whenever you deal with the patient, you'll come to know that is most important. Whenever you go to the patient side, always counsel them with the empathy, connect with them empathy. You know, when empathy is involved, they'll be comfortable and they may share many things, like whatever they are feeling after taking certain medication, whether they are willing to take any medication or not, what are the condition, or else whatever the symptoms they are developing, it has been developing with the various drugs. So they can explain in detail and you can take the decision. You cannot take a decision completely based on document, and document is important to communicate between the teams, but the condition of the patient is important whenever you communicate with the patient. So documentation and the condition, the both are involved in the clinical pharmacist role, which plays a very key role in the patient decentering the continuum of care and the deprescribing also. So these days, nowadays patients became a toy to apply all the brands. Many pharma companies, they are trying to give many medications which are duplicating also, to check with their brand how it is working and all those things. It cannot be done. Whenever the clinical pharmacist is there in the healthcare, the it must ensure that patient safety is going on over there by reducing the duplication of the drug, and by reducing the polypharmacy, and by reducing the same mechanism of the drug, and by reducing the adverse drug reaction, to prevent medication errors and to analyze the new drug information to the consultant whenever it is needed. You are supposed to give it to the healthcare professionals. It might be anyone, either nurse, because she plays a key role during administration, and the consultant, before prescribing, he has to know what is the condition of the patient and what is the information of the drug before prescribing. They cannot prescribe randomly. So here the PharmD people plays a very key role in the medication expertise. So these people have, I can say only the clinical pharmacist has a decision making in de-prescribing or else any positive de-challenge or re-challenge or any withdrawal or else any addition or else any antidotes to be applied, benzodiazepines to be applied or else any withdrawal of the medication based on the condition of the patient is the right person. Clinical pharmacy is the right person, I can say. And among
Excuse
all
me,
these
ma'am.
things, use safe tampering protocols. See, whatever we have discussed till now, everything is as are included in this slide. That is, we have to follow and we have to provide written de-prescribing plan. See, documentation, as we discussed, documentation is always important where the
Excuse me,
de-prescribing
ma'am.
plan. Yeah, please.
Can we just wrap up in 5 minutes? Actually, we have some time constraints right now.
Yeah. There will be only one case study. It will be finished.
Okay, yeah. Thank you, ma'am.
Okay. And use a schedule follow-up to assess withdrawal efficacy or symptoms recurrence, document all the changes in the medical record, that is a case sheet, educate caregivers and the pharmacist involved. So these are the 5 points to be followed for the communication, for the documentation within the healthcare departments to avoid multiple polypharmacy or else multiple duplication to the patient. So next thing is system level consideration. Involve clinical pharmacist in review. If you are working in any healthcare, try to involve clinical pharmacist to review all these conditions, whatever we have discussed, and use EMR alerts. If any high risk drugs are prescribed to the patient, try to use EMR alerts so that every consultant and the healthcare givers whoever involved they'll be alert before giving it to the patient or else before finalizing the drug and the dose of the patient also. Conduct periodic medication reconciliation at all the care transitions. Medication reconciliation is most important, and the same time encourage interprofessional collaboration, that is pharmds, mds, rns, everyone. This is also important. We have to encourage to follow all these channels into the healthcare professionals. And the useful tools for de-prescribing is, I think you have heard from the morning sessions too. Stop and start care pocket guide and the base criteria app and WHO guide for to good prescribing and the de-prescribing algorithms. See, whenever you are dealing with the healthcare, whenever you are dealing with the direct patients, these top two are involved and these are both important. Stop and start criteria, you are going to check the conditions, and the base criteria is applied only in the geriatric patients. And before applying these tools, you have, whatever we have discussed, you are going to assess the patient condition, at the same time the medication too. So these are the slides, and if we can go to the case study, we'll check one case study. Which case can we go to the geriatric or else oncology or palliative care? Can we go to palliative care?
Yes, ma'am. We can move forward with that case.
So if time permits, I thought of going for elderly also. False, or else we can go with the palliative care. Is it visible?
Ma'am, your presentation is visible. The case is not visible.
Yeah, 1 second. There are 3 cases actually. One is geriatric, one is post-discharge. Let's go for the palliative care.
Dr. Akla, you need to share again.
Yeah. Is it visible?
Yes, ma'am, it is visible.
So let's go to the practical scenario, how we are going to do the deprescribing in the palliative care. See, patient condition is the case summary. Patient is 65 years old male, and the condition is metastatic cancer and advanced stage, and the medication count is 12. Deprescribed medication. So as we discussed about the condition where I have showed you in my presentation is statins. Used for long-term cardiovascular prevention, biophosphonates used for bone protection in osteoporosis, iron supplements may cause GT distress with limited benefit in late-stage cancer. Care focus is symptom control, comfort, pain management, outcome, improved quality of life, reduced patient medication side effects. So, the straight away with the geriatric patients, as we discussed how to apply the Bayes criteria, we have to exclude the statins, biophosphonates with and iron supplements because these are the conditions. In the mets cancer, already patient is on a palliative care, where he cannot go on the radiotherapy or chemotherapy. So we can remove these 3 which are leading harm to the patient. So the outcome, how this component and how can be applied these things in the case. The clinical indication is statins and biophosphonates no longer provide meaningful benefit. See, as the condition is the patient condition is palliative care, but how statins and biophosphonates can be used to the patient, there is no meaningful, so we can deprescribe it. And the prognostic context, so life limit illness, limited expected survival. As patient is already on a meds and it is on an advanced stage, so we can deprescribe these medications. And the patient goals are comfort, dignity, relief from physical and emotional burden. See, if medications are if you reduce the medication list of medication, then psychologically we can give only a psychological support during the palliative care of the patient. So we something it may reduce some emotional burden. And family or caregivers role is involvement in understanding the goals and preferences. Whenever you are deprescribing the medications, you have to counsel them with the clinical condition of the medicine and of the patient also. These medications may not be useful further if we continue also. So communicate with the caregivers. And the shared decision, discuss deprescribing options and rational with the patient and the caregivers. So whatever you have taken the decision with the deprescribing in the palliative care of the patient, the decision you have taken to be ensured for the patient safety, you have to counsel the caregiver and the family. At least they have to know why those patient medications were decreased and what is the condition. So next is justification of the deprescribed drugs. So as we discussed, statins. Why we have deprescribed the statins? Because it prevents long-term cardiovascular events. Patient is on already condition of palliative care. We cannot give more risk by giving statins, and no mortality benefit in palliative care also. If we continue this medication also, there will be no use. And with the multiple of medication, it may lead to the serious, something very critical condition, drug interactions, or it may leads to the multiple medications may give multiple side effects. So we can reduce that. uh, and the biphosphonates used for the osteoporosis and bone metastasis. Already metastasis was done and the patient is on advanced stage, so we cannot repair anything. So the things we can deprescribe is which may cause GI upset, and at least we can already, during metastasis patient will be on a very uncomfortable situation. They'll be unable to swallow the water too, so it may lead to the GI upset. At least it may subside from the RN, that is a medication, and help we can help from our end to the patient to subside all these things. And the iron supplements, it's very common in anemia. If patient is on first stage or else any second stage, till fourth stage it might be useful, but there will be no useful if we check the life expectancy of the patient. Now where we have to focus, we have deprescribed the three classifications on the based on the condition of the patient. Now our focus is care plan, preventive medication, symptom relief, that is opioids. Patient is always on a pain in the meds, so we can give only meds. Pill burden from 12 medication, already patient is on multiple medications, so if three classifications of drugs are subsided, then there will be only 9 drugs and it will be essential medication only. And the risk of polypharmacy complications, as we discussed, if there will be a multiple drug interactions, multiple adverse drug reactions, multiple known side effects, so we can reduce the medication to avoid the risk of polypharmacy. And the disease focused approach is comfort focused and the holistic care. Now the disease, if we focus the disease condition, we are in the helpless where patient cannot take any chemotherapy or any particular radio or any, they cannot survive for long with any further higher end medicine. So that is the reason now we are looking for the patient comfort. If we go through the broader condition and implication in the palliative care, if we consider the goal of care and the strategy is align treatments with the dignity, comfort, and the patient personal wishes. At there will be some legal norms. We cannot deprescribe immediately with our own decision. So there will be ethical practices and there will be some communication. There will be a concern from the caregivers or any family members or patient. We have to take the concern and we have to take the symptom management priority also. See the here in this condition, the priority symptom is to optimize pain. Obviously, with the multiple things and the meds, there will be having a breathlessness, anxiety, pain, nausea, vomiting. There will be a multiple conditions more than these things. Like so, that is the reason we can avoid stats also. And the discussion, like whenever we deal with the multiple things, there will be legal situation where we are going to face. That is the reason informed consent and the legal document from the caregivers and the family members is mandatory, along with our signature with our registration number. And the continuum care of care integration is this pharmacist, physician, and the nurse collaboration. These whenever we are going to take the decision, we are supposed to take a teamwork decision also before going to deprescribe the medication or else condition. Knowing the condition of the patient, we have to collaborate with all the departments, healthcare, with the healthcare professionals. And the tools to support deprescribing in the palliative care is there will be always, as we discussed this research, this is a expected based on the life expectancy on the, and the stop tool we can use, an NNT calculator we can use, how to prevent the, if any, how to identify if preventive drugs are no longer beneficial. So based on the NNT calculator is that will be helpful for us to knowing about the therapeutic condition, especially the therapeutic condition of the patient, that is of the drugs in on the patient, that is duplication, especially duplication. So these are the tools we can see, the uh, uh, tools we can see during deprescribing on the patient. So this is the practical scenario how to deprescribe the medication, and which will be very useful for the family only. and you are the and you play a very key role where you people know the better about the medication and the condition of the patient. So these are the tools and how to apply, and they where how you can deprescribe the medication is unnecessary mechanism, unnecessary medicines which may not be used to the patient based on their quality of life and the life expectancy. This is an example of the case, and if you need any further, we can discuss something needed, if any needed, who are working on a healthcare itself. So Ajit sir will guide you for the rest of the things. Thank you. Hope everyone understood who are working in the healthcare especially.
Thank you very much, ma'am. It was really an insightful session. Now we'll move on for the Q&A session. I think there are no questions. So I guess it was very detailed and insightful session on your topic, and they understood it very well. Now, I'd like to request everyone to turn on their cameras so that we can click a picture.
Yes, chill.
Thank you, everyone. You can turn off your cameras now. Thank you, Dr. Akhila, ma'am. It was such a meaningful and inspiring session. You reminded us that deprescribing isn't just about stopping medicines, it's about starting conversations and building trust with every patient. Now, with this, we come to the conclusion of RAMCON 2025 scientific program. It has truly been a day filled with knowledge, reflection, and collaboration. Now, I hand over the stage to Insha, who will continue the session. Over to you, Insha.
Thank you, Devanshi. What an enriching day it has been. From thoughtful deprescribing in cardiology and oncology to the role of artificial intelligence in the medication management. Today's session has empowered us with knowledge, sparked dialogues, and reignited our commitments to patient centered care. I now invite Dr. Ajit Singh once again to deliver the vote of thanks as we reflect on today's learnings and shared purpose. The stage is yours. Thank you so much.
Thank you, Insa. Thank you for your nice hosting, introduction, and everything, guys. But I think first we should announce the winners. Then only we should go for a vote of thanks. What do you guys say? Let's do the announcement of the winners. Then I'll go for the vote of thanks. Is it okay?
Yes, sir.
Yeah. Please go ahead with the winners because these people are waiting. And I will also suggest all of you to share the feedback form because I can see people are waiting here. People are with us since 9 o'clock in the morning, and they should get the certificates as well if they are here, right? So please share the feedback form, and along with that, please announce the winners. And let's
Yes,
go
sir.
ahead. Please, just stop sharing my face here. Yeah,
Thank
thank
you
you.
so much for staying with us till the end. It's now time to celebrate the hard work, dedication, and brilliance of our participants. Let us begin with the oral presentation category. The winners of the oral presentation of the top 10 category are Fatima Juhana, Tasmia Banu, Ganjala Hemalata, Varikupala Monica, Ashu K. Manaswini, Shivani Chaudhary, Wammi Nagasai Venkata Durga Niharika, Khushi Sharma, and Muhammad Abdul Malik. A huge round of applause to all our finalists. Now, out of all our wonderful participants, we had 3 individuals whose performance really stood out. The winners of the top 3 overall positions are: the third place goes to Khushi Sharma. Second place goes to Fatima Johanna, and the first place goes to Shivani Chaudhary. Congratulations to our winners. And now, recognizing the efforts of our video presentation category, the participants who has made it to this round are S. Mega Varsha, Abhirami Raja Shekhar, Banuja Shakti MC, Dr. Ramsha Ahmed, Mani Vasakam Prakash, Adiraj J, and Alisha Khan. Congratulations to all the winners. We hope this is just the beginning to many more achievements to come. With this, I would like to
Can you please tell who is first position, who is second rank, and who is third rank? That will be great
yes,
for
sir.
everyone
Yes,
to
sir.
know. Yes.
For the oral presentation, we had first position Shivani Chaudhary, second place by Fatima Jahanna, and the third place by Khushi Sharma. Congratulations, guys.
Wonderful. Congratulations, guys. Many
So you
congratulations
can,
and thank you for participating. Yes, please go ahead with the next.
so that's it. Yeah,
No, video presentations.
I just said it. The winners of the video presentations were S. Mega Varsha.
Ranks were there. I think some were case presentations and all. Well, okay, okay, it's fine. It's fine. You please go ahead with the presentations. Okay. So just give me, I'll just do it. No problem. It's fine.
Okay, sir.
Okay, yes, thank you. Thank you very much. Just give me a second, guys. Give me a second. I'm just, something is downloading actually. Just give me a second. Okay. By the time you guys please share the feedback form again, so these all can, fill it, please share the feedback form once again. Yes. Just 1 second, guys. Yeah, I got it here. Laptop is a little slow, but that's okay. So guys, are you all here who have submitted the, video presentations and all the, abstracts here? Are you all here? So are you excited?
Yes, sir.
See, first of all, let me tell you how it went. We asked for the, abstract submission to this, and we thought we'll give only 10 prizes, only 10 prizes. Okay. And literally, you won't believe we got around 65 abstracts in just 3 days. And we, turned off the portal of the submission by 15th. And after that also, I mean, we did not accept after 15, but after that also, you won't believe 150 abstract have been submitted till yesterday. 150 abstract. We did not consider any because this is, not at all, what we say ethical. If I, consider the abstracts who have been submitted after 15 because 15 was the last date. So out of 62, 10 abstracts have been selected for the top 10 presentations in the, oral category in the conference. And out of that, as just Insa has told, these three got top winners, but all 10 are winners. Okay, don't feel like, these are just top three out of 10. Otherwise, all 10 are winners here. All 10 are winners of oral category, and they will get the equal prices. They all will get the equal prices. Okay, so let me tell you what you are going to get. First of all 10 are going to get the certificate with top 10 category. Okay, category of top 10, right? And then in that also, top 3 will get the rank certificates, and all 10 will get the equivalent price from our side. Okay, and then if I come to, let me just share a bit, let me share this screen with you. Yes, 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 guys, chill. Okay, so let me share this with you. Okay, so this is the video presentation. Out of 65, we asked everyone to prepare the video and submit. You know, we asked everyone to submit the presentations, so we can assess and everyone will get a fair chance of presentation, right? Because everyone is working hard and everyone is doing these projects. And out of these, as you can see here, finally we selected 8. See, many of you did multiple mistakes. Someone has just uploaded the Word file, someone has just uploaded the screenshot, someone has uploaded the without ppts. I mean, lot of things were there. But out of that, around 35 presentations were neat and clean. And out of those 35, we selected 7 presentations for 3 ranks. And 3 ranks, how we categorize? We categorized into 2 categories: one case report and one paper, right? Original paper. So out of case reports, if I say there are 2 selections, only 2 case presentations were there, and both the case presentations were wonderful. I was in the assessment team. I checked, both the presentations were really, really wonderful. So in that, the first rank and second rank we chose. So first rank went to S. Meghavarsa and second went to Abhirami. First, I mean, was the case was on torsemide spinal electron induced Steven Johnson syndrome, and second was methotrexate induced abnormal uterine bleeding. Okay, and these people are from Kripanidhi College of Pharmacy, Bangalore, and Ajutachan College of Pharmaceutical Sciences, Trivandrum, both. So they got the first and second rank in the case report. And then if we come to the papers, there are again 3 ranks, but first rank goes very clear to one, and second rank also goes very clear to one, and third rank there is a tie between 3 people. Okay, so let's check the names. First rank is Bhanuja Sakti, who has presented clinical outcomes of inhaled corticosteroids withdrawal in COPD. This was a wonderful presentation. We will try to upload everything on our YouTube channel. You check out. This is wonderful presentations they did. They presented very well. She is from Siddhaganga College of Pharmacy, Tumkur, Karnataka. And the second presentation was Dr. Ramsa Ahmed, study of various complications associated with pregnancy and their effect on maternal and fetal health. And she is from Sri Aurobindo College of Pharmacy, Aurobindo Institute of Pharmacy. And the third rank is shared by all 3, Mani Vaskam Prakash, Adhiraj, and Alisha Khan. So first is from the Tamil Nadu Dr. MGR Medical University, Chennai. Second is CL Bed Mehta College of Pharmacy, Chennai, I believe. Integral University, Lucknow, the third one, who is sharing the third place from Lucknow, Uttar Pradesh. So these 3 got these ranks, and everyone is going to get award, right? So guys, thank you first of all for presenting, and thank you for submitting the abstract and making this conference wonderful. And I congratulate all 17 people. All 17 are winners to me. All submitters are winners to me. Okay, no one is like everyone is winner who has taken this courage to submit the abstract. They all are winners to me. But there are some regulations, there are some rules to define the your skills of presentation, making the presentations and all, and the quality of the case, novelty of the case. So based on that, definitely we define the ranks. But all 17 and all submitters are winner to me. Right now it comes to the awards, as all will get the certificates of the presentations, all will get the certificates of ranks, and everyone will get this is a surprise for all. And I am very happy to announce this for the first time. This is being announced here only. We are launching the course. We are launching the course for the first time in association with Association of Community Pharmacists of India, ACPI. And this course is Deep Prescribing Science and Polypharmacy Management. Till now, today, you just got 6 sessions by different people, but now you are going to see everyone, and with our course director, Dr. Neha, in the entire course. This is a 3 months course. This is a 3 months comprehensive professional certificate value-added course in deep prescribing science and polypharmacy management. So first of all, let me congratulate all 17. You all will get free admission to this. You all 17 will get free admission to the prescribing science and polypharmacy management, free of cost to this course. You don't have to pay any fees. Okay, this is the award to all of you. And this course is about lectures, interactive case studies, simulation sessions, and mini project also is included, right? So it will definitely help you in equipping the, with evidence-based strategies to optimize medication regimens, reducing the harm, and applying the deprescribing principles in varied clinical context. Okay, so I'll share this definitely with you all, right? So this is the we have the target audience, doctor of pharmacy students and the clinical pharmacist, and people who are working with special populations like geriatric populations and medical and nursing professionals, healthcare administrators. And you can see the syllabus, the comprehensive syllabus is here: introduction, pathophysiology, pharmacokinetics. We have digged it completely, digged it, and we went completely deep down to understand the concept of deprescribing and the patient-centric approach, right? Identifying the inappropriate medications, as you just were learning about stop, start, med stopper, Beer's criteria. Everything will be cleared here. Deprescribing process, risk benefit assessment, clinical judgment, and case-based workshops will be there, multiple, and then ethical legal communication challenges, interprofessional collaborations, what we need, workflow integrations, MTM, medication therapy management, and case-based workshop, complex scenarios for two, and then capstone project will be there for all of you. Okay, and definitely you will get the certificate criteria, reading packs, you will get the beer on stop tools with you with this course, landmark studies you will get, and deprescribing algorithms also you are going to get from this course. Okay, and you are going to learn all these things with the mini project. And the cost of this course is just 799, because it is again CSR funded, right? CSR funded course. It will be 3 months course. Every Wednesday there will be the class from 7 p.m. Okay, there will be the class from 7 p.m. every Wednesday, and course is starting from July 16, right? Last date to registration will be June 30th, and we will extend definitely because we just have a limited time, 8 days. But so this is live 100% online course. You can register 799 only for this. Okay, and course director is Dr. Neha, and everyone who just saw, you will get. So I'm very thankful to Dr. Nagappa sir, the president of ACPI, who understood the need of this course and who accepted our collaboration to deliver this course to the population. And I'm also recently appointed as the national coordinator and ACPI core committee in charge for National Student Consortium of ACPI. So I'm very thankful for that also to sir and the entire team of ACPI. So along with that, we are developing the ACPI definitely. ACPI is a very big and old group. From 2008 they are running, but it was not in the students till now. Right now we are penetrating into the students, we are penetrating to the society. Until now it was the professionals, group of professionals, it was the association of professionals, right? But right now we are developing it into the students as well, right? So this course is in collaboration with ACPI and completely developed to understand the science of deprescribing. So with that, guys, I again congratulate all of you. I am so this course will be definitely helping you out for in learning the deprescribing medicine and all. So now I'll come to the vote of thanks. So first of all, let me thank our all the people so who have joined the rationalizing medication, a patient-centered approach to deprescribing and managing polypharmacy. This is the conference we have just done with. We have just done with the it was the wonderful conference. It was a great conference. I was the whole day I was in the conference, and I learned a lot from our fantastic people who came and who delivered the great lectures, who delivered the great lectures. And this here, it was a lot of things what you have learned even, right? So I would like to thank our resource persons, Dr. Akhila, who has just delivered the wonderful session, and then Mr. Saeed Mohsen Kadri, who has joined from Abu Dhabi directly, and Dr. Anita from the KMCH Coimbatore, and Dr. Priyansi Saha, who has joined us from the Parul Sevastram Hospital, Vadodara, Dr. Neha Srotia, who is with us right now here, author and educator, Dr. Pravalika. So I would like to thank all of them to, deliver the wonderful, wonderful, wonderful lectures and wonderful sessions. So, we got to learn a lot of things, and our participants also got to learn a lot of things. And yeah, so, and along with that, I think, one second. Okay, so we got to learn a lot of things from them. And then I would like to thank our hosting team, who has, tirelessly working since yesterday night, and actually from the yesterday only. Okay, yesterday morning, they were tirelessly working with the faculty members with, making the scripts. And I would like to thank our hosting team, who were really wonderful, and seamlessly they have conducted the entire conference and presentations. Ms. Tanvi, who is the head of our social media team from the internship June batch, and then we have Insa Sheikh, Shivani Mandal, and Devansi Broth, and other people from the social media team. And then other batches and other clubs of our, June internship batch. There are social media team, there is, editorial and magazine club, society, and there is, organizing team, networking team. So they all, have worked a lot to conduct this, conduct this conference. And it was really a big success because we got around 550 registrations, and out of that you have seen here almost 300 were completely, the entire day there were 300 participants in this conference. And I would like to thank, not but the least, but you guys are the best. I'm telling you, all the, people who have supported us, who have, had the trust in us, who have registered to this conference. I would like to thank you all, because without you, it was not a success, right? Without you, without the audience, any conference is not a successful conference, right? So it was a wonderful conference, successful conference. We learned a lot. I would like to thank everyone. I would like to thank the organizers. Our all the teams, clubs. I would like to thank all the resource persons. I would like to thank my audience. And guys, at last, I would like to say to you, please, don't run behind me for the certificate. You will get it by next Sunday. I'm giving you the maximum, deadline. Otherwise, you will get by Wednesday only. By Wednesday, we will deliver all the certificates. But for the safer side, by next Sunday, you will get all the certificates for the presentations, for the participation. Everyone will get your certificates by next Sunday. Okay. So I would like to thank, and thank you everyone. We can now wind up. Please, fill the feedback form for your attendance and for your feedbacks. Please do that. So it will be very helpful for all of us. Okay. Yes, guys. Thank you very much. Over to you, Insa.
Thank you so much, sir, for your kind words and continuous support. With this, we officially conclude RAMCON 2025. On behalf of ClinMed Academy team, I extend a heartfelt thanks to all the attendees, speakers, and mentors for making today a grand success. This is Insha Sheikh signing off. Thank you and have a wonderful evening.